We're all set and we can start at your mark, Dr. Osama.
Bismillah ar-Rahman ar-Rahim. Dear delegates, doctors, distinguished speakers, Assalamu alaikum and good evening or good morning from wherever you are. While there remains no curative treatment in recent years, numerous disease-modifying therapies have been approved for multiple sclerosis treatment. For this reason, a profound knowledge of the characteristics and indications of the available compounds is required to tailor the therapeutic strategy to the individual patient characteristics. This should include the mechanism of action and pharmacokinetic of the drug, the safety and efficacy profile provided by clinical trials, as well as the understanding of possible side effects. Tonight, IVPN NeuroPsychiatry, supported by Janssen Neuroscience, is organizing this education activity to discuss the management of MS with focus on disease-modifying therapy and symptomatic treatment. Today, our eminent MS experts coming from Saudi Arabia, United Arab Emirates, and Lebanon will provide a comprehensive overview on currently approved therapies in MS and the emerging evidence-based strategies to adopt for the management of this disease. Stay with us until the end of this activity, as we will have an interactive case discussion session during which you will interactively participate by analyzing the cases shared and vote whenever it is applicable. Before introducing our first speaker, I would like to thank Janssen for sponsoring this education activity, to specifically mention Dr. Sally Amara for always supporting IVPN activities and caring towards knowledge transfer of MS therapeutics, pharmacoeconomics, and disease awareness to our region and beyond. Special thanks to the Gulf Medical University, our amazing strategic partner. I would like also to recognize the remarkable leadership of Dr. Maya Zainuddin in leading IVPN neuropsychiatry activities, and Dr. Hussam Salamat for leading the webinars operation, and to the talented Anfal for her amazing flyers designs. This event is special as it will be the last event before the summer vacation. Please enjoy this fruitful webinar. So now it's my honor and pleasure to introduce our first speaker for this evening, Dr. Reem Fahd Al-Binyan from Saudi Arabia. Dr. Reem is the CEO of the Center for Improving Value in Health, which is part of the evolving transformed health system in the Kingdom of Saudi Arabia. Reem is an American board-certified neurologist who is super specialized in multiple sclerosis with rare expertise in pediatric multiple sclerosis and practices at King Fahd Specialist Hospital, Dammam. Dr. Reem is the president of the Saudi Multiple Sclerosis Advisory Group. She chairs the National MS Registry Steering Committee. Dr. Al-Binyan attended medical school at King Faisal University, Dammam, graduating with honors and receiving the Prince Mohammed bin Fahd Award for the academic excellence. Dr. Reem then went on to the residency training in neurology at the University of Louisville, United States, followed by an initial fellowship in clinical neurophysiology and neuromuscular disorders. At a personal level, I was honored and privileged to work with Dr. Reem Al-Binyan for 4 years when I was the director of pharmacy at King Fahd Medical City. Hello, Dr. Reem, how are you?
I'm doing great. And
it's always nice to meet you, Allah.
It's great to be here. Assalamu alaikum and good evening, everyone. It's a pleasure to be with you this evening. A double pleasure to be with you, Dr. Osama. And thank you to Dr. Maya and the organizers for tonight's event.
Excellent. Dr. Reem, the stage is yours for the coming 35 minutes to speak on the pharmacotherapy of MS, injectable and intravenous disease-modifying therapies. تفضلي, Dr. Reem.
Thank you very much. And welcome everyone to tonight's event. It took me a while to put this talk together for you, realizing that this is the last event for this year, and realizing that it's the second part of the event that focuses on the topic of multiple sclerosis. So I will start by sharing my slides. Let's see. All right. So in the coming 30 minutes, I will start by warming you up to a discussion on DMTs in general. You will be hearing about DMTs, the injectable type, injectable and intravenous type, with a focus in this talk, and you'll be hearing about oral treatments in the next talk. I thought that it would be very meaningful to spend a few minutes to focus on the various considerations in the use of DMT in people with multiple sclerosis, because I, as a practicing neurologist that focuses on people with multiple sclerosis, I know that the variety of factors that are involved in decision making is an important element for clinicians, whether the treating neurologist or the nurse coordinator, the pharmacist, and realizing that the focus or the special interest perhaps of the audience tonight is more so on the pharmaceutical properties, and as Dr. Osama mentioned, the pharmacoeconomics. And with my renewed focus on the topic of value, which I will be very happy to engage with you on questions on at the end of this presentation, is the importance of focusing on outcomes that matter the most to people that are receiving care relative to the effort, or what we are now referring to as the burden of therapy among people with MS. So the first few slides are going to warm you up to this, and I hope you'll find this useful. So let's start with general considerations related to disease-modifying therapy, DMT, in MS, and the multiplicity of factors contributing to decision-making. And a word to start with is that the field of multiple sclerosis and disease-modifying therapies in people with MS has rapidly evolved over the last 10 years, more so than it ever did before that. So MS is a heterogeneous disease. So when we speak about therapeutics, and this is one of the reasons I spent some time trying to think about a nice flow for this talk for you this evening. So the first thing to say is that it's not one condition. Well, it is one condition, but it's very heterogeneous among people that are affected by the disease. And the first consideration is to understand what type of condition we're talking about from the perspective of the clinical and radiological features. So you can see on this slide the various clinical phenotypes: radiologically isolated syndrome, clinically isolated syndrome, in which the patient would have a single episode, whether it's monosymptomatic or polysymptomatic, benign MS, which usually we can only tell that it's benign after the passage of a number of years. The most common type is relapsing remitting MS. And then we have the progressive types, secondary progressive and primary progressive, that are less common among the total population of people with MS. This is an important slide because the clinical trials over time have changed their focus, have addressed these various types of clinical phenotypes, realizing that even the definition of these various clinical phenotypes have changed with time. The McDonald criteria have evolved over time. The MRI criteria have evolved over time. So just keep that in mind when you're reading the literature. The next is to talk about, and you'll see each slide focuses on a different thing. So this slide is a reminder that it's a heterogeneous disease and that there are two types of damage that affects the tissue. Focal damage in focal lesions, or what happens or what is expressed clinically as a relapse, and diffuse damage that typically happens. It's less of an inflammatory process, and it happens over extended periods of time. And many clinical trials have focused on the diffuse damage with studies that focus on medications that reduce the loss of brain volume over time. And we are slowly building our understanding in this field. The next is on the natural history, the clinical expression of the disease. And you can see in the slide, a simple message from here is that the number of clinical relapses is clearly related to the level of disability that a person would experience over time. And so this is an important consideration when choosing treatments among the various therapeutic options. And I'll come to that in a moment when we speak about the disease activity. The next is on the radiological features. And you know, and you heard about this a lot in the first session on this disease. MRI is the closest to coat biomarker that we have in people with MS. And the disease burden, or the burden of lesions on MRI, is an important prognostic feature to consider when choosing among the various therapeutic options. And the next is is a reminder to all of us clinicians taking care of people with MS, is that there is clear evidence that if we suppress the inflammatory process early on in the disease, this will result in a better prognosis in the long run. And I think I have a slide that shows how this has evolved over time. Oh, this is I'll stop here for a second just to give you a moment to absorb the evolution of the development of therapeutics in the last number of years. The first drug that was available for MS is also an injectable. Part of the focus of this talk is interferon therapy in the 1990s. And for a long number of years, it was the only option that we had. And we switched among the different interferons, which we no longer do in our practice today. And over time, a number of other agents have proven to be efficacious in MS. And you can just take a look. I'll come back to these details as we go forward. I think this is the one that I wanted to zoom in on. And it also demonstrates the evolution of therapeutics and the significant change in prognosis and the conversation that we have with our patients has significantly changed over time with the development of more efficacious and safe immunotherapies for people with MS. And so I'll explain the graph just to have you soak it in. The green line, or the green and blue line, demonstrate people that were diagnosed in the 1980s and 1990s. And you can see in the y-axis, the probability to reach EDSS score of 6 was close to 90% at that time. You can see the circle in red, 84% in 1990 versus 2010. And then the red line, which is at the bottom of this graph, shows that the likelihood of reaching an EDSS score of 6 goes down to closer to 20%. And so it's a statement to the efficacy and the importance of starting disease-modifying therapy early in our patients. The next, and so you've heard about pathology, you've heard about the clinical phenotype, heard about the MRI features, evolution of therapeutics over time, and now I'm showing you a slide that speaks about prognostic factors. Now, in the day-to-day clinical decision-making, we use a lot of these factors in consideration. It's not so easy to have it's not so easy to have this conversation with a person that you're either starting on a new therapy or switching from one type to another. Because of the complexity of these factors. So a single prognostic factor that's on the favorable side or more versus a single or more poor prognostic factor. But with the availability of the variety of treatment options for our patients today, it helps us narrow down and it helps us get closer to the optimal option for our patients. The next couple of slides also demonstrate that when we start, if we miss the moment to start therapy in people with MS, we cannot recover the likelihood of a person having a higher level of disability with time. The optimal window is the first 6 months after the diagnosis is made, or within the first 6 months of when the diagnosis is made. You can see that the disability accumulates and you cannot recover this later. And this is another slide that shows a similar point, but emphasizing the likelihood of moving into a secondary progressive phase. So it's a specifically addresses the secondary progressive phase of the disease. So here I would like to stop for a moment and also address an aspect of care and decision-making in the choice of DMTs that involves shared decision-making. I think this is a very important aspect of care that we need to be extremely mindful of, more so today than ever. It shows the shift in focus from the clinician's perspective, but also from the person receiving care. And I think nowadays, we really need to, as we make a recommendation for disease-modifying therapy for our patients, to really make sure that the decision is co-created between the clinical team that has the advantage of more knowledge of the pharmaceutical features, the safety profile, the aspects of burden of care. But the person that's receiving care, because oftentimes they have very specific objectives that they would like to achieve through the care plan, that we really need to pay close attention to. In my own experience, I've become a better listener, I want to say, to our patients, in the sense that sometimes we're speaking about injectables, and I'll come to the details of these injectable agents. People that are receiving care, they have views on the qualities of a therapeutic option that they are more comfortable with, or they would like to learn more about. And so this slide that drives us a specific message in the sense that the traditional goals have evolved. And so it used to be that we would aim to stabilize the disease, whether it's clinical or from an MRI perspective. But nowadays, the objective of care is complete absence of evidence of disease activity, what we call NEDA, no evidence of disease activity, whether clinical or radiological. And usually we try to align closely with patients on the objective and the way we would monitor their care. So here is the transition to speaking about the specifics of therapeutics. And so choosing the right therapy for the right patient keeps in consideration everything that I've said so far, in the sense that there are factors that relate to the patient, himself or herself, the disease itself, and the options in therapy. So I'll start in the middle of the slide, where I speak about disease factors, duration of disease, whether the individual has been on other therapeutics and has not responded or has had side effects, prognostic factors that we spoke about, and are we at a point of initiation of therapy? Are we at a point of escalation of therapy? Are we at the point where we're having a conversation about adverse events with one agent or more than one agent? Do we have considerations for family planning, pregnancy? Pregnancy in my practice is always part of the conversation, specifically when the person with MS is a woman. There are other factors that are patient factors. On the left side of the slide, you can see comorbidities, likelihood to adhere to a care plan that requires frequent dosing, personal preference, and you heard me talk about shared decision making, and I'll repeat it a few times during the talk. And lastly, on the right side of the slide are factors that relate to the therapeutic agent. And this is important. I realize that today's audience is from, I think you said 15 countries or more. These factors are sometimes are the most important factor when you're making the decision with your patient. If medication is not available, so you may not be able to offer that to the individual, or the individual may not have the option to receive it. Mode of administration, if we're speaking about injectables versus oral, if it's an infusion, if they have an access to an infusion center or a hospital or home care where they would receive the infusions, an injectable where an individual needs to learn how to do those injections, insurance. Payment models are important factors in the treatment options for your patients. So I prefer to skip on this. I'll come back to the progressive because I think I put this slide to speak something about progressive care, but I want to move into the specifics on the therapeutics. Spend a few minutes here because this is the real part of the talk I'm sure that the audience is very curious about. And so I will spend the next 5 minutes or so speaking at high level on the names of these injectables and high-level considerations for mechanism of action, safety, and the monitoring of these agents. So on the slide, you'll see the first two injectables are gluteramate acetate and beta interferon. In my country, Saudi Arabia, gluteramate acetate until very recently was not available. And so we have rarely had a chance to offer this therapy to our patients. I am sure many of you have the experience or the exposure to the use of this agent. It's a subcutaneous injection that's administered daily. It's indicated for people with relapsing remitting multiple sclerosis with disease activity. And it's a specific agent that is an option for women in childbearing age because of its safety profile. It's a fairly safe medication that's easy to take. And the monitoring is very light. In practice, one of the side effects of this injectable is injection site reactions, which oftentimes is the reason for switching from this to another agent. The other factor would be lack of response. The second one you see on the slide is beta interferon. And there are several types of beta interferon, and there are several brand names for this. Beta interferon 1A comes in two forms. One form is called Avonex, which is an intramuscular injection that's administered weekly. And one kind is called Rebif, which is a subcutaneous injection that's administered 3 times weekly. And the third one is betaferon, or other brand name is beta interferon 1B, which is administered subcutaneously every other day. The main thing to say about interferon therapy is that they have been around for many years, and we understand their safety profile very well. They're safe, and we now know that their safety profile for women in childbearing age is really great. We can even administer these medications during pregnancy if needed. In most situations, women, when they get pregnant, they prefer not to be on any therapeutic agent, which we do too. The safety profile is really one of the main reasons that we prescribe this option. The side effects can be troublesome. Flu-like reaction, myalgia, a mild fever or headache, but mostly people that are on this treatment, they tolerate it after the use of the medication, after about 6 weeks of being on this medication. Oftentimes nowadays, because of the broad variety of agents that are available for people with MS, people may decide not to receive this option as a first-line agent because it's an injectable, if they prefer not to be on an injectable for that purpose. But these two, the first one and the second one, are indicated for people with mild to moderate disease activity with relapsing remitting disease. Now, the next agents are monoclonal antibodies. And you can see on this slide the agent that's called ofatumumab, which is similar to the other agents because it's a subcutaneous injection. It's an anti-B cell therapy, anti-CD20, and it's in a formulation that's for subcutaneous injection. And people with MS can self-inject, and it's an agent that has proven efficacy in people with highly active disease. And it's considerably easy to administer, doesn't require to be in an infusion center or near an infusion center. And the safety profile is very similar to other anti-CD20 in the sense that we need to do some screening for hepatitis B and C, HIV, and tuberculosis prior to initiation of therapy, and the risk of adverse effects during therapy is fairly low. Moving into other agents, I will start on this slide with the bottom one because it's similar to the one that we just heard about. It's called ofatumumab. This one's called ocrelizumab, also an anti-CD20 in a formulation that's intravenous, administered every 6 months with a similar pre-treatment considerations, low side effect profile when it comes to the infusion reactions. The formulation is really easy for patients to receive, yet they would require a mechanism for which they would receive the infusion, whether through an infusion center, hospital, or at home, if that's available to them. Ocrelizumab has an additional feature that the clinical trials have shown its efficacy among people with progressive disease, which is a breakthrough in our understanding of disease-modifying therapy and their effect among people with progressive disease. Moving up on this slide, so we're going bottom up. The next agent is called natalizumab. Natalizumab is a treatment option that's an anti-integrin. You can see the mechanism of action spelled out in the slide, which means that it blocks the entry of cells into the through the blood-brain barrier into the CNS. And it's been around since the early 2000s with evidence of efficacy among people with highly active MS. It's a monthly infusion that, you know, when in clinic, when we have the conversation with patients that are already on the treatment, they consider this to be like magic. It typically really controls the disease activity, has minimal side effects, and is very tolerable. Now, one important consideration for safety is the risk of PML among people that are treated with natalizumab. And we were having a little chat among the panelists before starting the webinar, in that patients who are JC virus positive or seroconvert to positivity should not receive natalizumab more than 2 years, a total duration of therapy, because the risk of PML increases among these patients. And PML is a very serious side effect that is an important consideration, an important safety consideration among people with MS. And the rate of seroconversion among people with MS perhaps is a little bit higher than the rest of the population. We typically would need to monitor the JC virus status every 6 months. And in the case of seroconversion, we usually switch. We can have more of a discussion about this during the Q&A. Some clinicians, they monitor the titers. Generally speaking, once a person seroconverts to positivity, it's safer to switch them to another agent beyond the 2-year mark. The next therapy on this slide is alemtuzumab. Alemtuzumab is an anti-lymphocyte monoclonal antibody, anti-CD52, and it is an intravenous infusion. And the way it's administered, usually we would explain it to our patients. It's a one-time therapy where they would receive IV infusions for 5 days in a row in the first year, and then they would receive what we would describe as a booster after 12 months. This therapeutic option gained a lot of popularity when the clinical trial was published and became available. And it was at a time when B-cell therapy was less, the evidence for B-cell therapy was less available. But it's a treatment option that is, there's a caution for a broad range of adverse effects of this therapy. Whether it's infusion reactions, usually the recommendation would be to admit people to hospital for the infusions, because the infusion reactions are more common. And then after the infusions, people would need to have monthly blood work and urine analysis for a period of 5 years after therapy, which is an important consideration when you're treating people with MS for where they live, their compliance, because the risk of these side effects could extend for extended periods of time. I'm close to the end. I know I'm close to the time mark. So this is an algorithm that we developed with MS experts in Saudi Arabia that's part of our national guidelines for therapy. And I'll show you another one that's a European one for your reference. Now, algorithms are great for a general guide, but from what you've heard during today's conversation, you realize that the decision-making is multifaceted and not really linear. And you can see that the injectables and intravenous therapies are side by side with the oral agents for choices, where in the past it used to be the injectable would be the last of the options that you would get. But you see here that among patients with active or highly active relapsing remitting MS, whether they're treatment naive or non-naive, you will have B-cell therapy as an option. We use rituximab quite a bit in our practice, even though the clinical trials were done on ocrelizumab and ofatumumab, yet we use it clinically with proven efficacy, and real life experience publications are out there. And you see in aggressive multiple sclerosis, on the second box, you see the option of alemtuzumab. Mitoxantrone is no longer part of the treatment algorithm for a majority of people with MS. And this one is from a publication, from a European publication that is very similar to the one that I just showed you. And it shows in a similar way the broad variety of these injectables and how they are side by side with oral options for therapy. I will be happy to speak about progressive disease if the audience is interested in it, but I probably should stop here, because otherwise I will ruin the flow of the program. Over
Not
to
at
you,
all.
Dr. Osama.
Not at all, Dr. Reem. It's always nice to have you with us. That was very comprehensive presentation. And let's start with two questions. With the introduction of oral and intravenous disease-modifying drugs, the question is, do injectables and interferon still have a place in the management of MS given their low tolerability by our patients?
I would say yes. Yes, because of the safety profile. Generally speaking, most people who receive the interferon therapy tolerate it well. Most people do. Some they don't. Our threshold to switch is low. In my own practice, I continue to offer interferon therapy among other agents and actively engage in shared decision making for that. But I realize, to the person that asked this question, I realize that there is a big variation among neurologists and even among patients in their choice for that.
Excellent. We have another question. The question is, when do we initiate a newly diagnosed MS patient who is treatment naive on high efficacy intravenous medications such as ocrelizumab or natalizumab?
That's a really great question. So we generally, when we make the diagnosis, and I usually explain to patients that we have two boxes. The first box is the diagnosis, and then the second box addresses the treatment plan. Once we make the diagnosis, I'll start by a statement in the sense that once we make the diagnosis of relapsing remitting MS, we recommend immunotherapy. Point. Now, the choice of immunotherapy goes to the high efficacy drugs if the disease activity is high, or if the disease is aggressive. And we can go into specific definitions, but generally speaking, if the clinical relapses have been severe and polysymptomatic, or if the frequency of relapses over the period of time since the diagnosis, and it varies among patients that come to see us, we would start on high efficacy right away.
Excellent. Excellent. We'll take one more question, if you don't mind. What are the advantages of induction strategy over escalation strategy in the treatment of MS, and which one do you prefer?
Also a great question. Thank you to the person that asked it. Induction therapy is an area of interest and an important area of discussion among neurologists or treating teams. It used to be more popular in the past than now, because oftentimes these treatments you would start and you would continue. And to better define induction therapy is oftentimes you would consider a treatment option where you would address the disease activity aggressively by a treatment option, and then you would either continue that same treatment option or you would switch to another choice. In my own practice, I don't use the term induction therapy. I typically discuss with the patients a switch or an initiation of a therapy of a different type, depending on the circumstance that we're addressing specifically, if it's a severe attack or if it's new diagnosis or otherwise. Alemtuzumab is sometimes considered in a type of induction therapy. in general, in my own practice, I don't use that approach. I hope that answers the question.
It does. It does. You know, we have one more question from Muhammad Mahdi. What is the position of pegylated interferon in the management of multiple sclerosis?
Also a great question. They're all great questions. Pegylated interferon is a form of interferon therapy that is administered every 2 weeks. It's a longer acting type of interferon that became available a number of years ago. In my view, and this is a personal opinion, in my view, the pegylated interferon does not specifically offer a solution, if that's a good way of explaining, does not offer a solution to an issue with the treatment. And oftentimes, the tolerability of the pegylated interferon is not very high. So there is no big advantage of pegylated interferon versus the other. I personally don't have experience with it. We never obtained it in our multidisciplinary MS clinic. So I personally have not had the experience with that. It does have a place in the algorithm for therapy, and it fits among the interferon therapies. And so that would be perhaps a discussion that you would have with the patient if it's available to you to switch to it, because it's a less frequent dosing. And so maybe that's where it fits.
Dr. Banyan, you know, thanks for sparing the time and being with us this evening. Is a great pleasure. And we hope to see you with us in future events as well.
I would love to, and I thank you so much, and thank you to the audience for your presence with us.
Thank you.
Shukran.
Best regards to our colleagues in our beloved Saudi Arabia.
Shukran jazeelan. Shukran. Bye-bye. Ma'as-salam.
Bye, ma'as-salam. And now it's my pleasure to introduce our second speaker, who's really known to probably all of you. We have Dr. Maya Zainuddin. Just a second, please. Dr. Maya, bear with us. Here we go. Dr. Maya is a Lebanese senior clinical pharmacist specializing in neurology and multiple sclerosis. She is the winner of the Best Clinician and Positive Attitude Awards. She completed several internships at major hospitals and community pharmacies in Lebanon and the US, and graduated from the Lebanese American University with a Doctor of Pharmacy degree with distinction in June 2011. In August 2015, she successfully passed the multiple sclerosis specialization examination and became the first multiple sclerosis certified pharmacist in Lebanon and the Middle East. From September 2011 till August 2020, she worked as clinical pharmacist of the MS Center at the AUB MC. In December 2015, she was appointed as Executive Secretary of the Middle East North Africa Committee for Research and Treatment in MS. Dr. Zainuddin is an active researcher and is involved in several international clinical trials in the field of MS, and is a member of several national and international professional organizations. Dr. Zainuddin is also the fund coordinator at the National MS Society of Lebanon and the leader of the NeuroPsychiatry listserv at IVPN. Dr. Maya is currently a PhD candidate at the University of Limoges, France. Dr. Maya, how are you today?
I'm muted. Fine, thank you, Dr. Osama, for this introduction.
So I will leave the stage for you, Dr. Maya, for the coming 35 minutes to speak on the pharmacotherapy of MS, oral disease modifying therapies. تفضلي دكتورة مايا.
Thank you so much again, Dr. Osama, and thank you for all our audience who joined us today for our last activity for this season before the summer vacation. So without further delay, let me start my presentation, and I will discuss. Dr. Reem already discussed with you and gave us a great overview about the injectable and intravenous medication, as well as how to use all this medication and how to choose which is the right medication for the right MS patient. I will be discussing with you the oral disease modifying therapies. So here are my disclosures. And then I will move to my first slide. So this is a very nice time frame that shows the evolution of the treatment of MS over years since the 1990s, and Dr. Reem showed you a similar nice chronogram. So as of 2021, we are lucky to have more than 19 approved branded disease modifying drug in the US, but as well in Europe, and they are all available all around the world. And if you can notice, before 2004 or 2005, we didn't have so much option or many option for the treatment of MS, and our treatment option were limited to injectable drugs, and those were discussed by Dr. Al-Bunyan, interferons and glatiramer acetate. Then in 2005 or 2004, the first monoclonal antibody, which is an intravenous medication also that Dr. Reem discussed in her presentation, natalizumab, which is given as an infusion in the hospital every 4 weeks, was introduced to the market. It was the first intravenous medication approved for MS. But until we didn't have any oral option for MS until 2011 with the approval of fingolimod, the first oral DMT that was approved for the treatment of MS. And with the approval of fingolimod, really the era of DMT and of MS treatment has emerged, and we currently have more than 19 drugs approved for MS. Many of them are actually oral DMT. So beside injectables and intravenous medication that Dr. Reem tackled in her presentation, we have many oral options that I will be discussing in detail during my presentation. And we have many other drugs coming in the pipeline. Some of them are also injectable, high efficacy injectable, and others are oral therapy. And we have also few intravenous medication. So let's start with the first oral medication. So the first oral medication I will discussing is teriflunomide. So if you look at this chronogram, teriflunomide was introduced around 2014 in the market. So it's a once daily, it's an immunomodulator drug and not immunosuppressed, a suppressive medication that was approved for the treatment of relapsing remitting MS. Selectively and reversibly inhibit an enzyme, which is the dehydroorate dehydrogenase enzyme, which is a key mitochondrial enzyme involved in the de novo pyrimidine synthesis. And pyrimidine is essential for the spread and for the proliferation of B and T cells. And as you know, multiple sclerosis, and as we discussed in detail during the part 1 of this webinar, last month, multiple sclerosis is a B and T cell disease where autoreactive B and T cells, they are involved in the pathogenesis of the disease. So stopping the proliferation of B and T cell will stop the progression of the disease, and this is what teriflunomide actually does. It inhibits this enzyme responsible of the proliferation of B and T cells, and by stopping dehydroorate dehydrogenase, we stop the proliferation of autoreactive B and T cells. And protective immunity is not compromised by teriflunomide. And in preclinical study, in animal study and in vitro study, teriflunomide was not genotoxic, mitogenic, or clastogenic. It means it does not cause cancer or cause other autoimmune disease or affect our innate immune system. In terms of efficacy, it was approved based on 2 phase 3 clinical trials, the TEMSO and the TOWER trial. And in both studies, teriflunomide successfully decreased the relapse rate by 30% compared to placebo. And similarly for disability progression, it had a robust effect on disability progression as it decreased the 12-week, this confirmed disability progression by again 32% compared to placebo. Regarding its side effect profile and safety, the most common adverse event of concerns of interest of teriflunomide are increased liver enzyme, hair thinning, not alopecia, it's hair thinning, so it causes hair loss, especially during initiation of the medication. Usually the first 1, 2 to 3 months, then this side effect will disappear or will decrease with the continuous use of the medication and will not have any more hair thinning. But we should notify mainly our female patients about this side effect before initiating teriflunomide. Also, diarrhea was a common side effect with teriflunomide, but also it resumed with continuous use of the medication. Headache, influenza, and nausea too are very rare side effects. So mainly we are concerned about hair thinning and increased liver enzyme. And for the increased liver enzyme, it is recommended, if you look at the label of teriflunomide, to monitor the liver enzyme on monthly basis. So every 1 month, we should ask our patient to do SGPT, SGOT, the transferase, the blood test, in order to monitor the liver activity on monthly basis for the first 6 months upon initiation of teriflunomide, then every 3 months for the first year, then every 6 months thereafter. And as I mentioned, with liver enzyme, of course, we should monitor the CBC every 3 months, then every 6 months. Also, before initiating teriflunomide, we should screen our patient for tuberculosis. So a PPD test should be requested for all our patients before initiating teriflunomide. And this is because teriflunomide might reactivate tuberculosis. So if the patient has any positive PPD test, he should be referred usually to infectious disease specialist, and they should be started on isoniazid prophylaxis for 6 months. Teriflunomide, although it's a new medication, relatively new, it was approved in 2014. However, we know a lot about its safety profile from its active metabolite leflunomide. So leflunomide is the active metabolite of teriflunomide is the active metabolite of leflunomide, and leflunomide is an FDA approved drug for rheumatoid arthritis that is has been used since the 1980s, and we have millions of patients who use leflunomide, and we can extrapolate all the long-term safety data of teriflunomide from our experience with leflunomide in rheumatology. Moving to the second oral disease-modifying drug that was also approved in a similar period with teriflunomide, it is dimethyl fumarate. Dimethyl fumarate is a twice daily oral, also immunomodulator that is approved for relapsing remitting MS. So the mechanism of action of dimethyl fumarate is still not fully elucidated. We don't know too much about it, but we know that dimethyl fumarate activates both the antioxidant and anti-inflammatory response through activation of the NRF2 pathway in the nucleus of the cells. So it activates the NRF2 is activated by dimethyl fumarate, and it activates the intrinsic defense mechanism that will lead to increase in the antioxidant response and decrease in the inflammatory response, which is usually enhanced in multiple sclerosis. So that's the role that's the mechanism of action of dimethyl fumarate. It's again an immunomodulator that does not cause immunosuppression, and it comes into a hard capsule, enteric coated. Usually we start with a low dose of 120 milligram. I will tell you in my next slide why. Twice daily for 7 days. Then after 7 days, we escalate for the maintenance dose of 240 milligram twice daily. In the phase K clinical trial, it significantly decreased the relapse rate compared to placebo. So it led to a 50% reduction in the relapse rate compared to placebo, and also for the disability progression, the 12 and 24-week disability progression was significantly decreased by 30% in patients who received dimethyl fumarate compared to placebo. And based on this clinical trial, it was FDA approved for the treatment of relapsing remitting MS. What are the common side effects of dimethyl fumarate? Flushing, gastric side effect, mainly diarrhea, nausea, abdominal pain, are the main side effect or the common side effect of dimethyl fumarate. But usually these events, mainly the GI event, they occur in the first 2 to 3 months after initiation of the treatment, and then decline with continuous use of the medication. Also, similarly to teriflunomide, we have, or we can extrapolate the long-term safety data of dimethyl fumarate from its another metabolite, fumaderm, which has been registered for the treatment of psoriasis since 1994 in Germany. And until today, we don't have any serious event or cancer cases or autoimmune disease reported with fumaderm. And from here, we can extrapolate the long-term safety data for dimethyl fumarate from fumaderm. So they are safe over the long term. So for the GI side effect, as I mentioned, the incidence is around 40%. So 40% of the patient who will be initiated on dimethyl fumarate will experience gastric side effect. However, as you can see from the graph, the intensity is the highest in the first month, and then it subsides with continuous use of the medication. And excuse me, only 3% of the patient will discontinue treatment due to GI side effects. What are the strategies, or what are the recommendations that you should give to your patient to mitigate the flushing and GI side effect? That's why we start with a low dose of 120 milligram twice daily for 7 days. We take the medication with food. Excuse me, we temporarily decrease the dose to 120 if we experience side effect, then we escalate back to 240. And if we experience a flushing, patient should be started on aspirin before each dose of dimethyl fumarate. Excuse me. Moving to another class of oral disease modifying therapy, which are the S1P receptor modulator. So fingolimod is the first S1P receptor modulator, and actually fingolimod is the first oral DMT that was approved in 2010 for the treatment of MS. It's given once daily. So what are S1P receptors? They are receptors that are located on the lymph node, and the role of this S1P receptor modulator of fingolimod is to internalize this receptor and to downregulate this receptor. And by regulating this S1P receptor, we inhibit the lymphocyte to egress from the lymph node into the peripheral circulation. So what fingolimod does is that it traps the lymphocyte, the activated lymphocyte, the B and T cells, mainly T cells, into the lymph node and prevent their circulation into the periphery, and therefore their entry into the central nervous system, and prevent the damage to our nerves. So this is the mechanism of action. And keep in mind that fingolimod does not kill lymphocyte, does not kill T cells. So although when you initiate a patient on fingolimod and we do a CBC, we'll see a significant decrease in the lymphocyte count. However, whenever we stop the medication and if you repeat the CBC 1 month after discontinuing fingolimod, you will see that the lymphocyte count will recover back to normal. And this means that fingolimod, it does not kill the lymphocyte, it only trap them into the lymph node, and it prevents them to circulate into the periphery and therefore recirculate into our central nervous system and cause the damage responsible for the MS symptom. This is the efficacy data of fingolimod from the Freedoms and Transforms study, which are 2 clinical trials, and based on them, fingolimod was approved. The Freedoms trial compared fingolimod to placebo. There was 54% decrease in the relapse rate, 30% decrease in the 3 and 6 months disability progression, and also significant decrease in the or improvement in the walking and cognitive and clinical parameter compared to placebo. The Transform study, they compared fingolimod actually to an active comparator, which is interferon beta 1A intramuscular, which is Avonex. So they compared it to another MS medication, interferon, and it actually showed a significant decrease in the relapse rate by 52% compared to interferon, and 30% also decrease in the disability progression. Side effect of fingolimod, mainly with the first dose, you might experience bradycardia. Macular edema is a very, very rare side effect. It is reversible. It's a rare one. We should monitor our patient for this. I will talk about this. Hypertension also is a common side effect, a reversible increase in the blood pressure. Pulmonary dysfunction in patients with lung diseases, skin cancer, some cases of melanomas were reported with fingolimod in the clinical trial and in the post-marketing phase. Increase in liver enzyme, we should also monitor LFTs similarly to other medication, and case of PML, which is the rare brain infection caused by the JC virus, is also some cases. We have report of some case in the post-marketing phase of fingolimod, so we should keep in mind this. Before initiating fingolimod, we should perform some pre-treatment tests for all our patients. CBC, liver enzyme before initiating. EKG should be obtained before starting a patient on fingolimod. Make sure it doesn't have any cardiac abnormality. Baseline ophthalmic exam to rule out macular edema before starting. We should obtain varicella zoster serology because fingolimod can reactivate zoster infection, and there was 2 cases of death in the Freedoms and Transform trial due to zoster infection. And if the patient has negative VZV antibody, they should be vaccinated before initiating them on fingolimod. And usually we vaccinate the patient, we repeat the VZV antibody titer after 1 month, and once positive, we initiate the treatment. Of course, we should avoid initiating fingolimod because fingolimod is not like teriflunomide and dimethyl fumarate, who are immunomodulator drug. Here we are talking about an immunosuppressive medication, so we shouldn't start if the patient has active infection. And fingolimod, the first pill of fingolimod should be given in the hospital under monitoring. So patient should be admitted for 6 hours, where usually our MS nurse will monitor his blood pressure, heart rate every hour. We perform a baseline EKG, of course, baseline vital sign and blood pressure, and we observe the patient for 6 hours with continuous measurement every hour for his blood pressure and heart rate. And at the end, we repeat the EKG before discharging the patient home to make sure that he doesn't have any bradycardia or AV block or any cardiac problem. And of course, if the patient develop any symptoms, we usually transfer him to the cardiac unit. We admit him for 24-hour monitoring. While on therapy, we should report any symptom of infection. We should avoid live attenuated vaccine because we are on immunosuppressive drug. We should perform ophthalmic exam at baseline, but also after 3 months of initiating of fingolimod, because the risk of macular edema with fingolimod is the first 3 months of treatment. So usually we do an ophthalmic exam at baseline, then we repeat it after 3 months to rule out that the patient doesn't have this problem. CBC and LFT should be monitored every 3 months. This was strict with fingolimod to monitor for lymphopenia and increased liver enzyme. So S1P receptor, fingolimod was the first S1P receptor and the first oral treatment approved for MS. And it actually downregulates, it's not a specific one, it downregulates S1P receptor 1, 2, 3, 4, and 5. And given that these receptors are involved in natural killer cells, central nervous system, smooth muscle, cardiac cells, conduction, AV and conduction system in the heart, endothelial cell, neuron, lymphocyte, it causes all these list of side effects. Now, in 2022, we have 3 more S1P receptors that were approved for the treatment of MS, and their advantage is the specificity to S1P receptor modulators. So we have ozanimod, that is an S1P1 and S1P5 receptor modulator. Siponimod, similar, S1P1 and S1P5. Ponimzimod is the most recent S1P receptor modulator that was approved, and it's the most selective one because it only downregulates the S1P receptor 1. I will not discuss ozanimod in my lecture because it's not available in our MENA region. I will discuss siponimod and ponizimod. So siponimod is a new selective S1P receptor. The advantage of siponimod that it was tested in secondary progressive MS, in actively secondary progressive MS, and it was actually shown to be effective in stopping the disability progression. This is the EXPAND study. Based on it, it was approved in SPMS. And before the approval of siponimod, we didn't have any treatment option or any approved DMT for SPMS. It's a double-blind randomized phase 3 study where siponimod decreased the 3 months disability progression significantly by 21% compared to placebo, and by 6 months disability progression by 26%. Also, when you look at or when you control for all the factors that could affect the efficacy of siponimod, so when you adjust for the sex, because male is a worst prognostic factor in MS, the previous DMT use, the number of enhancing lesion, the baseline age, the disease duration, and the disability progression, all the outcome were in favor of siponimod over placebo. So siponimod was superior even when controlling for prognostic factor and confounder over placebo, and it significantly stopped the disability progression and was effective in delaying disability in active secondary progressive MS. And also when they look into the SDMT, so SDMT is a clinical test that assess the cognitive impairment or the cognitive function in MS patient, and usually cognitive dysfunction is an early sign of progression in MS, that the patient is transitioning from a relapsing remitting phase to an SPMS. We can detect them by through his cognitive change in cognitive function or decline in his cognition. So actually there was an overall risk reduction for the decrease in anti-DMT by a more than 4-point score in the siponimod compared to placebo, and this was a 21.3% reduction in the disability, in the cognitive impairment worsening. And actually some patients had either stable or improved cognitive processing speed while on siponimod. And based on this data, it was approved. So it's the first DMT proven to decrease disability progression in typical SPMS population. There was, as I mentioned, 21% reduction in the 3 months disability progression, 26% reduction in the 6 months disability progression. Also in relapsing remitting patient, there was a 55% reduction in the relapse remitting, 23% brain volume decrease in the brain volume loss compared to placebo, improvement, as I mentioned, in the cognitive speed or stabilization, and 7-year delay in the time to wheelchair compared to placebo in SPM patient. As for its safety profile, it was well tolerated. It shares similar side effect profile as fingolimod. However, usually siponimod is also given once daily, but it is given, we titrate the dose over 7 days, and this will avoid we can avoid by this the prolonged cardiac monitoring and the admission to the hospital. But overall, for the infection, the malignancy, it shared the same side effect profile as fingolimod. So mainly siponimod is a patient who are in relapsing remitting phase transitioning to SPMS or diagnosed with SPMS but with active SPMS disease. The latest S1P receptor modulator that was approved is ponesimod. It was approved during the COVID-19 era in just last year. So the advantage is that it has no relevant effect on all other S1P receptor. It's very selective to S1P1 receptor. It's a potent modulator of this human receptor. So it's fourfold more potent than the other one. And it, as I mentioned, it has a different binding site than the other S1P receptor available. As for its indication, it is approved for the treatment of adult patients with relapsing form of MS with active disease defined by clinical or imaging feature. It comes at a coated tablet, and usually we titrate the dose over 14 days. So this is the regimen. On the day 1 and 2, we start with 2 milligram, then 3 on day 3 and 4. On day 5 and 6, we increase to 4. Then we increase gradually the dose until we reach a dose of 20 milligram daily. After this is the maintenance dose is 20 milligram once daily after starting day 15 and onwards. And it can be taken with or without food. It does not cause gastric side effect. It is given once daily orally, of course. So these are the prior to initiation to treatment. So as I mentioned with fingolimod, we need to perform EKG, and this applies for all S1P receptor modulator, ponesimod, fingolimod, siponimod, and ozanimod. Also, similarly for the CBC and liver enzyme, they should be monitored, and we should obtain a baseline CBC LFT profile before initiating an S1P receptor. For the blood pressure management, only with fingolimod, because with ponesimod, siponimod, and ozanimod, we didn't have any increase in the blood pressure. Ophthalmic evaluation in all patients before initiating S1P receptor modulator. Also, pregnancy test because S1P receptor modulator are contraindicated in pregnancy. VZV test should be obtained in all patients. It's similar for all. CP2C9 genotyping is only indicated before initiation of siponimod to test if we have any mutation in this enzyme. Otherwise, we could not give the patient or initiate the patient on siponimod if there is a mutation in CP2C9 enzyme. As for the first dose monitoring requirement, so with fingolimod, siponimod, and ozanimod, the patient should be admitted for 6 hours. To all patients who will initiate fingolimod. For siponimod and ozanimod, only patients with signs of bradycardia or first or second degree AV block or history of MI or heart failure, only those patients we admit and we monitor them for 6 hours. Otherwise, the titration of the medication will avoid this admission for the healthy patient with no history of cardiac disease. For ponesimod, we don't need to admit the patient to the hospital unless if they has again a history of MI, recent history of more than 6 months, or heart failure, a very recent history of less than 6 months before initiating ponesimod, or first or second degree AV block or signs bradycardia, but we need to admit them for 4 hours only to the hospital for cardiac monitoring. What about its safety and efficacy data? So the optimum study is the phase 3 clinical trial. Based on it, it was FDA approved for the treatment of MS. It's a double-blind, randomized, active control study. So also this is the advantage of the optimum study, is that it compared ponesimod to an active drug, which is teriflunomide. It's an effective one, and I already discussed teriflunomide in the beginning of my presentation. So they compared the patient were randomized to either ponesimod 20 milligram daily or teriflunomide 14 milligram daily for 108 weeks. Then there was a long-term extension study where all patients were shifted to the active drug or to the study drug, which is ponesimod. For the relapse rate, there was a ponesimod 20 milligram significantly decreased the relapse rate by 30.5% compared to teriflunomide, and this was statistically significant. a higher percentage of patients in the ponesimod group were relapse-free compared to the teriflunomide group. Actually, 62.3% of the patients were relapse-free, and this is a high number usually. And for the MRI or the imaging outcomes, ponesimod 20 milligram reduced the number of new enhancing lesion on brain and MRI by 56% compared to teriflunomide 14 milligram. Also, they assessed the disability progression, and EDSS is the clinical exam that usually neurologists use in their clinic to assess the disability progression. And actually, there was a larger increase from baseline in week 108 in the EDSS score in the teriflunomide group. As you can see, the teriflunomide group is the green light compared to the ponesimod. So more higher proportion of patients of ponesimod group, they remained stable with a stable EDSS. They didn't have any worsening of their disability progression compared to teriflunomide, where most of the patients progressed and had higher EDSS at the end of the study. Moving to another outcome, Dr. Al-Bunyan discussed our goal in MS. So traditionally, we used to use the term no evidence of disease activity 3, mean that patients should be stable, free of relapse, free of disability progression, and free of any new lesion on MRI. And this ponesimod met all these 3 outcomes, as I showed you in my previous slide. But nowadays, we talk about NIDA-4. NIDA-4 means we added, our scientists, researcher, and neurologists added a new outcome for our new targets in our treatment, is to decrease the brain volume loss and preserve or avoid the brain weight volume loss and protect our cognitive function in MS. And here in this in the optimal study, actually they assessed this, and actually patients who received ponesimod 20 milligram experienced less brain volume loss than those receiving teriflunomide. The relative risk reduction was around 0.34%, and this outcome was statistically significant compared to teriflunomide. So this is the percentage change in the brain volume loss over time. Ponesimod is the blue line, and ponesimod is the blue line, and teriflunomide is the green line. So as you can see, the brain volume loss was lower in the ponesimod 20 milligram compared with the teriflunomide 14 milligram group. So we have more protection of our brain volume in the ponesimod group compared to teriflunomide over time. This is the NIDA outcome that I just mentioned. So the NIDA-3, it is the disability progression, relapse, and MRI outcome, while the NIDA-4 include the brain volume loss. So at the end of the study, which is around 2.2 years after initiating of ponesimod or teriflunomide, a higher percentage of patients in the ponesimod 20 milligram versus teriflunomide group achieved both NIDA-3 and NIDA-4 status. So if you can see 25% in the ponesimod group compared to 16% in the teriflunomide for NIDA-3, and 11.4% in the ponesimod group compared to 6.5% in the teriflunomide group for the NIDA-4 outcome, which include the brain volume loss. Moving to its side effect profile, so when they looked at the serious adverse event and the treatment emergent adverse event, really the proportion of patients experiencing those side effects was similar between the ponesimod and the teriflunomide group, and there was no difference in those side effects. When they looked at the most common treatment related adverse event that occur at a rate of more than 10%, increase in liver enzymes, similarly to all other oral DMT, nasopharyngitis, headache, upper respiratory tract, were significantly higher or similar in both group, except for alopecia, which was the hair thinning side effect, which is the common side effect of teriflunomide, and which was detected higher in the teriflunomide group, and this was expected. So the most common side effect of interest that we should monitor are the increased liver enzyme, nasopharyngitis, headache, and upper respiratory tract infection with ponesimod. And the most common treatment adverse event in patients randomized to ponesimod were mainly the liver abnormalities, liver enzyme abnormality, followed by hypertension and pulmonary event. And that's why it's better to obtain pulmonary function test for patients with history of lung disease before initiating them on ponesimod. Monitor liver enzyme every 3 months like all other DMT, and monitor blood pressure for patients with history of hypertension or cardiac history. So the up titration regimen successfully mitigate the first dose cardiac effect of ponesimod, and that's why it's not recommended to monitor our patient upon initiation of ponesimod, except if they had a recent history of heart failure or MI or second degree AV block. So, but of course, we need to do an EKG before initiating ponesimod. Patient with risk factor for symptomatic bradycardia, they may require first dose observation for 4 hours only with ponesimod. And in the 2-year optimal study, ponesimod was not associated with an increased risk of cardiovascular event compared to teriflunomide. And we conclude from the optimal study, it is the first pivotal trial to demonstrate a superior efficacy of another effective DMT, which is oral DMT, which is teriflunomide. So it was not compared to placebo as for other S1P receptor modulator. It was actually compared to an effective DMT, which was teriflunomide, and it actually showed superiority. It was statistically significant. It had statistical significant effect have been shown of ponesimod on relapse rate, inflammatory lesion, and stabilization of fatigue. And also for its side effect profile, it was well tolerated, and all the side effects were in line or actually better than the other S1P receptor modulator. These are key safety considerations to keep in mind when comparing the S1P receptor modulators. So for the herpes infection and the herpes zoster, so herpes infection is high risk fingolimod, but they are common for all other S1P receptor infection. But until today, we don't, given that the rate of occurrence is less than 10%, we don't recommend to give any herpes prophylaxis with acyclovir or valacyclovir. For the herpes zoster infection, also it's common for all, higher with siponimod a little bit compared to other. Anyway, we should obtain VZV antibody, as I explained before initiating our patient on any S1P receptor modulated. There were no reported case of PML or cytomegalovirus infection with ponesimod, siponimod, and ozanimod. We have some cases of CMV and PML infection with fingolimod, probably because all other S1P receptors are still new, and usually PML developed with the use of these medication for more than 2 years. Macular edema, it's a very, very rare side effect, less than 1% or approximately 1% of occurrence. All what we need to do is to obtain ophthalmic exam before initiating any S1P receptor, and repeat this ophthalmic exam at 3 months after initiating it. Liver enzyme increase is common for all. Obtain LFTs before at baseline and monitor every 3 months our liver enzymes. A seizure is mainly observed with fingolimod in the pediatric population. Actually, fingolimod has a label and it was FDA approved not from many years. So in 2018, I guess, or 2019, it was FDA approved for the treatment of the pediatric MS, and and seizure was observed in the pediatric study. Otherwise, the rate of seizure was very low with other S1P receptor modulator. So and for the encephalopathy, it's not seen with S1P receptor modulators. So for the indication, so fingolimod, as I mentioned, is approved in pediatric, in children, also in relapsing remitting MS. Siponimod is for secondary progressive MS, active disease or patient transitioning. Ozanimod for adult with RRMS active disease. It's not available in our MENA region. And ponelizumab, it was recently licensed in June 2021 for relapsing remitting MS. For the second, the most selective one is ponezimod. It's only selective, it's only downregulate the S1P1, while they downregulate many other receptors. For the titration regimen, usually fingolimod, we start directly with 0.5 milligram daily, no titration, and that's why it's recommended to observe, to admit the patient for 6 hours and observe them. Fingolimod, we usually siponimod, we usually titrate for 5 days. With ozanimod, we titrate the drug for 7 days. The longest titration is with ponezimod for 14 days, and this will avoid us, that will avoid the 6-hour cardiac monitoring for our patient. No need to admit them again, except if they had a history of cardiac condition, then we admit them for 4 hours. Another thing that I want to highlight, two more things that I want to highlight, is the advantage of ponezimod, or the difference between ponezimod and other S1P receptor, is its elimination from the body. So it's eliminated after 7 days. So after 7 days, given its half-life, it is rapidly eliminating from the body, compared to ozanimod that need 2 to 3 months to be eliminated, 10 days for siponimod and 6 weeks for fingolimod. So this is an advantage, because whenever we need to shift from one medication to another, the washout period can be shortened to 7 days, or in case of pregnancy plan, or for any side effect or safety issue, and we need to shift or discontinue the drug, usually the effect is gone after 7 days of stopping the medication with ponezimod, while it's longer with other S1P receptor modulator. Also, for the drug-drug interaction, for patient on polypharmacy, there was no clinical relevant interaction with ponezimod and other CYP or UGT or transporter, while we have a significant drug interaction with CYP2C8 inhibitor, for example, and WOW inhibitor with ozanimod, and CYP2C9 and CYP3A4 with siponimod, and an interaction between fingolimod and CYP3A4 inhibitor. So keep this in mind whenever you have patients, especially on antidepressant, antipsychotic, and those are usually CYP inhibitor or inducer or MAO inhibitor and S1P receptor modulator. Also, genotyping is only indicated for siponimod. It's not required with all other medication. All the S1P receptor will cause lymphopenia, but this is a reversible lymphopenia, as I mentioned up in explaining their mechanism of action. But usually the lymphocyte count will return to normal within 1 to 2 months after stopping fingolimod, 10 days after stopping siponimod, 3 months after stopping ozanimod, and 1 week after stopping ponezimod. And this reversibility is important whenever we need to shift in case of treatment failure, and whenever we need to shift to a new disease-modifying drug. My last oral DMT that I want to talk about or discuss quickly is cladribine. So cladribine, it's also a potent immunosuppressive drug. It has a totally different mechanism of action. What the cladribine does is that it kills the autoreactive B and T cells. So it attacks both the B cells and the autoreactive T cells. It selectively attacks them. It kill them, as actually it decrease their number, and then after 1 month our immune system will be able to reconstitute a new set of B and T cells that are free of multiple sclerosis. Also, its mechanism of action is not fully elucidated, but reconstitution is likely to be a combination of quantitative and qualitative change in the lymphocyte. So we also have a qualitative change in the lymphocyte. We have less number of autoreactive T cells that will cause damage to the CNS. And again, cladribine does not affect our innate immune system. It was in the phase 3 clinical trial, it was significantly effective. It decreased the relapse rate by 58%, the 6 months disability progression by 47%, the imaging lesion or the lesion on MRI by 73 to 86%. How it is given? It's an oral treatment. It's a low frequency drug. In year 1, it is given at 2 short courses over 5 days on week 1. Then on week 5, we repeat the course over another 5 days. It is dosed based on the weight of the patient. So we have a formula and we dose it per milli per kilogram, and we calculate for the patient how many pills they need. Usually we have cladribine is marketed as a 10 milligram tablet. So we give the patient on week 1 over 5 days the first course, the second course on week 5 for another 5 days. So maximum of 10 days on year 1. Then we repeat the same course on year 2. So on year 2, we repeat the same 2 courses over again, total of 10 days. And then we don't give the patient any further treatment, and we monitor the patient over time. We might administer a 3rd course or reinitiate any other MS therapy when the patient will have a breakthrough activity. And actually the extension study of cladribine showed that 77.8% of the patient will not need any further treatment on year 1 and 2, and 75.6% of the patient will remain disease-free for up to 4 years after taking cladribine treatment. For the side effect profile, there was no significant difference in the side effect between cladribine and placebo, except for lymphopenia. So lymphopenia was significant with cladribine, of course, because of its mechanism of action that kill the B and T cell. We have 8 years data for its safety, so we don't have any reported PML until today, no risk of secondary autoimmunity. It does not cause any other autoimmune diseases. The lymphopenia usually is transient, mild to moderate lymphopenia, and is related, of course, to its mechanism of action. Grade 4 lymphopenia is observed in only less than 1%, and it is reversible. For the infection, the rate was similar to placebo, except for herpes zoster, which is more common with cladribine, and usually herpes zoster associated serious or adverse event were rare and again treatable. And we don't have any increased rate of malignancy compared with the general placebo, and the rate of malignancy is similar to other disease-modifying drugs. So given said that, just 2 words, 2 slides on how do we choose. So we choose based on, of course, on efficacy, safety, tolerability. So we have more than 19 drugs now approved. It's really, we have a lot of choice. Some are first-line treatment. First-line mean low efficacy drugs. Some are second and third line. So we go higher by efficacy. And as we go higher by efficacy, also we have more side effects that we need to monitor for. Also, we need to take into consideration the cost of this medication. It's not only about safety and efficacy. We do a risk-benefit ratio, and we add on top the cost of the medication, what our insurance cover. Also, before starting, Dr. Reem discussed this in a very nice slide. So we need to do a triage and to select what are the patients who have good prognosis of the disease and bad prognosis of the disease. And those are the criteria that will allow us to classify our MS patient. We need to discuss the spectrum of efficacy. So this is the numbers, the relapse rate that I retrieved from the clinical trial, but keep in mind we cannot compare this relapse rate because we don't have head-to-head clinical trials that compared, for example, natalizumab to fingolimod, but all those were compared to placebo, and you can see some drugs had low efficacy like teriflunomide, interferon, the injectable glatiramer acetate. They decreased the relapse rate by 30%. We go up, dimethyl fumarate decreased the relapse rate by 50% compared to placebo. Fingolimod, siponimod also by 50% to placebo. Ponesimod, it was superior to teriflunomide. We had an active comparator. 58% decrease in relapse rate for cladribine compared to placebo, and the monoclonal antibody have the high, which are the IV medication that Dr. Reem discussed, had the highest efficacy. So we need to discuss the spectrum of efficacy also, and based on after classifying our patient, where do they stand, and discuss the efficacy, the safety profile, check the affordability and the cost of the medication, then we can choose the appropriate treatment. Usually patient with a better prognosis, better to start them on low efficacy drug, and patient who has worse prognosis, we start them on high efficacy medication. And with this, I will end my presentation. Thank you so much. And just before moving to Dr. Tabbara, I would like to invite you all to our 7th NECTRIMS Congress that is scheduled next November in Cairo, Egypt. You are all welcome to it.
Dr. Maya, you always make us proud. You know, that was a very inclusive and enlightening presentation. This is despite your sore throat, but you made it very, very well. You know, we have 3 questions. We'll take 3 questions due to time limitation. The first question by Muhammad Azam: is there any available percentage for treatment discontinuation due to titration inconvenience?
No, actually, patients, they do well when they titrate a drug, and we don't have, and if you look at the data from the clinical trial, so we don't have a lot of data from our clinical experience because ponesimod was just introduced in the market, but from the clinical trial, from the optimum data, the rate of discontinuation was very, very low, and we didn't have any discontinuation due to the titration schedule.
Excellent. You know, the second, if a patient was on ponesimod and has to shift to another disease-modifying therapy agent, what is the washout period needed? That is a very interesting question.
Yeah, it's actually very interesting because whenever we need, especially when a patient is failing a medication and we need to shift, so we need to shift it quickly. We cannot waste time. A patient is having a treatment failure. We cannot leave him with an uncontrolled disease, with inflammatory status of the disease. So we need to control him. And this is actually the advantage of ponesimod over other S1P receptor because its washout period is only 7 days. So we can stop ponesimod, we wait for 7 days, 1 week, we repeat CBC. If we had recovery of the lymphocyte, we can initiate him on the new DMT, usually if we go for monoclonal antibody IV medication. While, for example, with fingolimod, we need to wait 6 weeks before initiating a patient on or shifting a patient to monoclonal antibody on new DMT.
Amazing. You know, the last question, what is the safety of S1P receptor modulators in pregnancy?
So this data can be extrapolated from the fingolimod pregnancy registry. So we don't have much data about ponesimod, ozanimod, and siponimod, the other S1P, because they are relatively new, but we have registry now going on. So for fingolimod, it is contraindicated in pregnancy, and it was teratogenic, and it caused actually fetal abnormality. The rate of abnormality was around 2 to 3%. So this is not too high, but we cannot ignore that S1P receptor can cause fetal abnormality. So usually what we do for any patient who wants to conceive and who was maintained on S1P receptor modulator, we advise her to stop the medication 4 weeks, at least 4 to 8 weeks before start to conceive. So usually we stop fingolimod 2 months before start conceiving, and then after 2 months she can start trying to get pregnant, and of course the drug need to be stopped during pregnancy, and then we resume. With ponesimod, given the short half-life, I think we have to stop like 1-2 weeks or 3 weeks maximum the medication, and then she can start to conceive. But of course, S1P receptor modulator are teratogenic, and we need to leave a washout period between the medication and start conceiving.
Excellent. Dr. Maya, thank you very much. Again, I thank you for your remarkable leadership and for being an amazing partner towards knowledge transfer of MS Thank you very much. You know, it's a pleasure now to introduce our third speaker, a prominent speaker from the United Arab Emirates, Abu Dhabi, Dr. Ahmed Osman Shatila, who obtained his BS in biology from Wayne State University in the United States. Dr. Shatila continued his medical education at the Medical College at Wayne State University. He conducted a residency in neurology at Wayne State University as well, and continued his fellowship in neurophysiology. Dr. Shatila interests include inpatient neurology, including but not limited to stroke, IV TPA program development, and status epilepticus. He is also interested in helping facilities develop a neuro-hospitalist model where inpatient care can develop independently from the outpatient services. This includes a combination of patients, resident, and nursing education, inpatient consulting services, and inpatient neurology services. Dr. Shatila is currently a senior consultant neurologist and head of the multiple sclerosis clinic at Sheikh Shakhbout Medical City, Abu Dhabi, with over 12 years of experience in the field of neurology. He holds an American double board certification in adult neurology and neurophysiology. Dr. Shatila has authored several neurology research papers with an emphasis on multiple sclerosis. He is also a member of several regional and international neurology organizations. Dr. Shatila, we congratulate you for this amazing achievements. And now it's my pleasure to leave the stage for you to speak on the looking beyond the surface management of MS symptoms. So you have 35 minutes, Dr. Shatila, and we are all listening.
Thank you very much, Dr. Osama, for the very kind introduction. I just turned on my timer. First of all, I'd like to thank the audience for attending today. I'd like to thank IVPN and Dr. Osama for inviting me to speak today about MS and how you manage the symptoms. And then finally, I'd like to thank Dr. Maya Zainuddin and Joel for lending me some of these slides, so their slides were better than my slides. So we'll go from there. So we're going to talk about MS symptoms. So when you talk about MS symptoms, why do people with MS want to talk about symptoms? What's so important about it? Symptoms are what people with MS live day to day. These are the silent things. Sometimes they're obvious, sometimes they're not very obvious. These symptoms negatively impact the quality of life. This has been shown in multiple studies. And the ability to participate in desired activities. That can affect your work, your home, your social activity. In a recent large NMSS study, people with MS repeatedly stated that their providers do not listen to them, and that people with MS seek recommendations that will help them live their lives best. Now, I don't like this study. It's actually a horrible study, but the results are very interesting. And the reason why it's horrible is that they looked at quality of life of people with MS as disability got worse. Once they got to a disability of 8, their quality of life was less than 0, meaning that people with MS, once they hit a disability score of 8, they would rather be dead than living. It's a good study telling you a little bit about MS. It's just horrible, that's so sad, that once the disability accumulates, these people would rather be dead than be alive. So what are the neurologic origins of the symptoms? Basically, MS is multifaceted. It can affect different parts of the brain differently. So depending where your lesion is, that's what you're going to get your symptoms. If you get a cerebellar lesion, you're going to get tremors, ataxia. You get brainstem lesions, you're going to get vertigo, diplopia, dysarthria. You affect the optic nerve, which is most commonly affected. You're going to get blindness in one eye. Sometimes it can be in both eyes. Frontal lobe is very important for inhibition, executive planning. So if you get that, you can get emotional disinhibition, or pseudobulbar palsy. You laugh at funerals, you cry at weddings. It's really emotionally disturbing for the patient and the family. And then when you get a bunch of lesions all over the brain, people start to lose brain mass, brain volume, and they start to have cognitive problems. So what are the important primary symptoms of MS? There's a lot of symptoms, but today we're going to be talking about these main symptoms: fatigue, cognitive issues, bladder bowel, sexual dysfunction, spasticity, mobility issues, visual disturbance, and altered sensation. So what are the secondary symptoms? This is a result of the primary symptoms. So Lack of mobilities or lack of emptying your bladder may cause infections, UTIs. Difficulty with cough or your gag reflex may get aspiration pneumonia. People with mobility problems tend to fall more. They injure their bones, break their bones. They can get injuries to their skin breakdowns. So those are the secondary symptoms of MS. What are the most common symptoms? I already spoke about some of this. Falls. The falls are due to weakness, spasticity, difficulty with coordination. It's not uncommon people with MS suffer from depression. It's more than 50%. Fatigue is a very common silent symptom of MS, with more than 95% of people complaining of fatigue. Cognitive dysfunction, extremely common, extremely silent, and a lot of times it doesn't even show unless you ask about it. And then, finally, we've got elimination dysfunction, bladder, bowel, urgency, or incontinence. What are the results of all of these symptoms, primary or secondary? The biggest problem is that they can lose their jobs. There's a high rate of unemployment with people with MS. And multiple studies have shown that by the first 10 years after diagnosis, more than 50% of people have already lost their job. Loss of intimacy, increased divorce rates, role changes, family disruptions. Maybe the primary breadwinner of the family could have been the man or the female, and if somebody has MS, it could be switched. Now the other significant other or the partner is now taking on multiple roles just to take care of the family, because the primary breadwinner can no longer achieve or do the goals or roles that they once used to do. And this can all lead to social isolation. People with MS tend to be more withdrawn. They don't want to go out due to a lot of problems. It could be the fatigue, could be the bladder problem, could be the constant pain. All of this leads to social isolation, making them more and more depressed and withdrawn. So when we look at symptoms of disease onset, if you look at all the symptoms right here, the most common symptom in over a third of the patients are sensory symptoms in the arms and legs. About 16% have vision problems. 14% have a polysymptomatic onset. 9% is motor. Then you've got people that acute motor, that's probably due to relapse. Diplopia, and then around 16% have a bunch of other symptoms that can't really be categorized under one phenomenon. Now, when we look at acute and chronic, most of the people with MS complain of chronic problems. Now, there is the acute problems, that's usually probably due to a relapse. Once the relapse settles and people have stabilized, then there's the chronic issues, maybe as a result of the relapse or due to the long-term injuries, and now they're suffering. And this is common: sexual problems, paroxysmal dysfunctions or symptoms, bladder, cognitive and spasticity, and it can hit almost up to 80%. Water. So what are the goals when we look at symptom management? The first goal is we want to eliminate or reduce the symptoms that impair a person's functional ability. We want to improve their quality of life. You want to avoid secondary complications, and you want to try to use targeted and individualized treatments of symptoms that are essential in the management of MS. So how does a multidisciplinary team help people with MS? In the center of this, you have the patient and their family. And then around this group of people, or your primary group of interest, you have the neurologist, the nurse, the NPs, the pharmacist, the psychologist, the therapist, social work, and many other people. So really a multidisciplinary team is not just patient and their doctor. It's really patient. Doctor is one aspect of a team of people that help out other people with MS. Because at the end of the day, no one person has enough time to deal with all the problems that a person with MS has. So it has to be divided as a team effort. Now, what's the problem when you have all these symptoms? You've got the MS symptom, and then you get this vicious cycle. The fatigue, depression, as it increases, people work less, do exercise less, and that can affect their spasticity, which then affects their bladder. All of this makes them sleep less, and finally, combination, you get cognitive dysfunction. And then you go back all over again. It's a vicious downward cycle, and the goal is you try to minimize it, control it, so you break that cycle, so at least you can actually break or prevent the worsening, or potentially cause some improvement in the quality of life of someone with MS. Let's first talk about bladder. Bladder dysfunction, about 70 to 80% of people with MS may experience problems with bladder. It's very common. Now you've got different types of bladder problems. You've got neurogenic bladder, which is urgency, frequency, incontinence, hesitancy, and incomplete emptying. Most commonly, people with bladder dysfunction, if they have an overactive bladder, they may not be able, the common thing is when you gotta go, you gotta go. So they gotta always look where's the bathroom. They can't drink a lot of fluids. They may be afraid to go out in public, especially in crowded places, because they have problems holding the bladder. Their bladder, because it's spastic, cannot hold the urine, and as a result, they need to go to the bathroom frequently and urgently. And what are the symptoms? Inability to store, inability to empty, and they could have the complete dysfunction of the detrusor, sphincter, the synergia. So when we look at bladder physiology, initial urge, it happens around 200 to 300 cc's of urine. Your bladder can hold around 500 cc's, and you're usually emptying around 15 cc's per second. Now, women tend to be slightly less than men at 30 to 60 centimeters pressure, and men is at 80. And then you've got the post-void residual, which is usually negligible in men and women who do not have any bladder pathology, meaning that once the bladder is contracted, there should be no urine left in the bladder. Now, what are the common bladder symptoms? I already spoke about some of them. Urgency, frequency, hesitancy, difficulty starting, double voiding, they stop, they start, they stop, they start, involuntary urine, either dribbling or leakage, nocturia, they gotta wake up at night, go to the bathroom multiple times per night. As a result of incomplete emptying, they may have UTIs, and then finally they may have dysuria or pain when they urinate. So bladder dysfunction, I told you there's three types. You've got the inability to store, the inability to empty, and then you've got the combination of the detrusor, sphincter, the synergia. So if we look at the inability to store first, this bladder is spastic. Because it's spastic, it tends to be smaller. So that means that it fills up faster, and once it fills up, you need to go, you need to empty it. And you may have incontinence because, it's like a reflex. Once the bladder expands, you can get involuntary contraction, and that involuntary contraction can be very embarrassing to people. Post-void residual, even though the bladder is smaller and it's more spastic, it doesn't empty fully. So you have a post-void residual more than empty. Now you got the other side. You may have a weak bladder muscle where now the bladder is floppy. It doesn't, it kind of it expands, it holds a lot of urine. They have a hard time starting. They may have they start, they stop, the double voiding, try to increase Valsalva, to empty their bladder. They have to go frequently because, again, their bladder is never empty. Goes to incomplete emptying. And because of that, they wake up at night multiple times. Again, because they have a large floppy bladder, the post-void residual is, again, large, and it can cause UTIs. Now, when you have the combination of the detrusor muscle and the sphincter, the synergia, so either your detrusor muscle is contracting, but your sphincter is not relaxing, or vice versa, you get basically a combination of the other two I just previously discussed. How do you assess bladder function? Thorough history. That's the most important thing. You need to talk to your patients. Now, it can get very embarrassing for women to talk to men about bladder problems and vice versa. Your male patients may not always talk to your female physicians. And that's why sometimes someone of the other sex may be important to help tease out some of these things that your patient may not be very comfortable to talk to you. You want to ask about voiding. You want to ask that you want to send them to a urologist to get a post-void residual measurement, whether they're emptying too much or if it's a weak bladder. And then you will look at causes, other causes of bladder dysfunction, UTIs, pelvic floor relaxation in women, or BPH in men. Now, the treatments for the inability to store, you want to try to limit the fluid intake. The less you take, the less you got to go. But again, you don't want to get dehydrated. You want to try to go frequent bathroom breaks. Go to the bathroom as often and frequently as possible in order to keep that bladder empty. Quick access to the bathroom. Many people with MS or many people with bladder problems will usually tell you first thing they do, they look for the bathrooms. They may have to wear pads or protective undergarments to protect them from leakage. And then also minimize the caffeine, aspartame, or alcohol, or any diuretics that may cause them to go to the bathroom more. And then finally, when all else fails, we try medications. We've got the anticholinergic medications, and we've got the alpha-3 and adrenergic agonists. So that's oxybutynin, tolterodine, Enablex or darafenacin, and meromegram. So we'll talk a little bit about the pharmacologic management of bladder. I'm not going to go in detail because there's a lot of medications, but they all kind of work the same way. These, well, most of them do. They're an anticholinergic. So you've got the oxybutynin, the tolterodine, the sulfenacin, the darafenacin, and the flavozate. I don't use that. We don't have that at our hospital. And then you got the hyoscyamine. I don't use that a lot as well. And then you got the DDAVP, and then Flomax, which is the alpha-2 adrenergic receptor agonist. Now, when you go to the anticholinergics, it relaxes the bladder, but you also get the anticholinergic effect, the dry mouth, the constipation, the headaches, the blurred vision. Now, ditropin works very well, but you get more side effects from it. I tend to use Vesicare, sulfenacin. Less side effects, it works just as well. So really the issue may be going down to insurance, what covers, what doesn't cover, and how much copay they have to pay. And if they have to, and if they failed that, then they're going to my colleagues in urology for a second opinion, nevertheless, to help out. What about treatments for inability to empty? Again, adequate fluid intake, structured time voiding. They may have to do intermittent catheterization again in order to drain that bladder. You can try the alpha blockers, like I told you, like Flomax or Cardura. They're also used for benign prostatic hypertrophy. They relax the sphincters, causing the bladder to empty. And then you can try also antispasticity agents or nerve blocks. So in summary, how do you manage? Your treatment goal is to maintain renal function. You want to establish normal voiding patterns and reduce the symptoms and improve the quality of life. You've got the non-pharmacologic treatments and the pharmacologic treatments, as I discussed. And then all of these are trying to prevent the secondary symptoms, the UTIs, overactive bladder, and public embarrassment. What about bowel dysfunction? 60% of people with MS may experience problems with bowel function. Common symptoms are constipation, diarrhea, and incontinence. Symptoms may be intermittent or constant, and they occur at any time in the disease. What are the most common bowel symptoms? Constipation could be due to slow bowels, could be due to medications. As I told you, you may be treating the bladder problem with an anticholinergic, and now they get secondary constipation. Or it could be also the fact that they're not moving as much. Activity keeps the bowels moving as well. So, if you're not physically active, your bowels are going to be physically inactive as well. Bowel incontinence, diminished sphincter control, or you may have a hyperreflexic bowel, meaning especially it gets exacerbated with spicy food. They eat spicy food, the whole thing goes through the system relatively fast. It can be embarrassing. So in summary, sorry, water. Bowel dysfunction management. Bowel training dietary modifications are recommended. So if you're constipated, increase your fluid intake. Increase your fiber intake, 20 to 30 grams per day. Try to eat bulk forming agents, stool softener stimulants, laxatives, suppositories, and exercise gets the bowels moving. If you're incontinent, you may want to do the other way around. You may go timed bathroom breaks. Use medication suppository to go to bathroom specific points in the day in order to, at least that you're going to go, and so you empty your bladder or your bowel. And you can do bowel training and timed evacuations like I do. Sexual dysfunction. Almost half of women and 75% of men with MS complain of sexual dysfunction. This can have a significant impact on the quality of life. And again, it's often an overlooked symptom. It's very embarrassing for the women. My female patients don't always want to talk about their sexual dysfunction to me. And I'm lucky I have a female nurse, and she's able to tease out this information. On the contrary, my male patients will talk to me about their sexual dysfunction, and they don't want to talk to my female nurse about their problems. So again, it does help to have someone of the other gender who works in your clinic to get these very embarrassing subjects out in the open, because even though they may be embarrassing to the patient, they're not uncommon and they occur. And the treatments may be a lot easier than the patient, what they may think. Primary sexual dysfunction in MS. Men and women can experience difficulties, decreased libido, decreased erectile dysfunction, ejaculation as a result of the medications or a result of the treatments themselves. Altered genital sensation. They may have decreased frequency, intensity of orgasms. They may have decreased vaginal lubrication or clitoral engorgement. increased bilateral spasticity, making it embarrassing to have sex, or all of this can make them increased in depression, thus decreasing their libido, and hence we start the cycle all over again. How do you manage it? You try to rule out any metabolic causes, and then your management strategies could be pharmacologic, treat the underlying disorder, try to adjust the medications. If some of the medications may have side effects, you block it, you stop it, positioning, lifestyle modifications. And the key to successful management is open communication. It's extremely important, like I told you. And then you also got counseling, and you talk about culturally sensitive support. It's a taboo subject. People don't like to talk about it, but it's very important. How do you manage it? Well, we have different ways to manage it. You got bupropion that can help increase for decreased libido or decreased orgasm. You can try that. You can try the sildenafil, the Levitra, Cialis, and
Sorry, there was a technical issue, Dr. Shatila. Can you try to share the screen again? Hello? Hello? Dr. Shatila, are you with us? Hussam?
I think it's from his side. We can wait for 1 minute to see.
Okay.
I think he'll rejoin.
We apologize for this technical glitch. We will be shortly with you again. Dr. Shatila is trying to log in. We apologize for the technical issues. Dr. Shatila is trying to get in. Oh, here you go. Yeah, Dr. Shatila, you are on silent mode, so something happened. Can you unsilent your, yeah, we can't hear you. Yeah,
sorry,
okay.
So I had some weird technological glitch. I don't know if something happened, but thank you.
Virtual world.
So let's reshare the screen. Okay, so altered mobility.
Excellent.
Okay, we got that. So where are we? We'll just go back there. We spoke about that. And this camera. So altered mobility in MS, I spoke. The causes could be the spasticity. They may have weakness. They could have cerebellar problems, balance, sensory loss. If you can't feel your legs, you can't move. Visual problems causing problems with balance. They may not be able to see things in front of them and they fall. What are the risks? Decreased safety, increased falls, injuries, impaired biomechanics. You have pain because you're using your joints and your muscles in ways that aren't made to be used, or you may be accommodating in different ways that can cause long-term arthritis or injuries. And mobility causing isolation and overall a reduced quality of life. As I told you, as your disability increases, your quality of life decreases. So how do you manage your mobility? Rehabilitation is very important, both physical and occupational therapy. You can use assistive devices such as canes, walkers, wheelchairs, crutches. Exercising is important. The idea is you want to strengthen the muscles that aren't weak and help them improve your fatigue, but also get the muscles that are weak stronger. You could try medications. We do have medications, delphinidine, I'll talk about that. And finally, surgery. You can do orthopedic surgery or neurosurgical interventions for spasticity. So what's one of the treatments for weakness? We've got delphinidine, Fampira in the UAE, and Pira in the US. And what does Fampira do? It basically blocks the potassium channel, thus improving the amplitude of the action potential, and thus kind of, instead of it being a wide, narrow depolarization, or a wide depolarization, it's more narrow and stronger, and thus you get a faster conduction velocity. And you get, by blocking the potassium, sodium, it basically go back to cell biology 101. The action potential gets stronger. But what does that do? It actually, in studies, 38% of people who took Fampira were responders, meaning that their 25-foot walk had at least a 25% improvement. So I usually tell patients, you walk faster, you walk faster for longer. And you know, one way you can address, you can do the 25-foot walk in your clinic. It's very easy. Just 8 meters, time it, and then take the medicine 2 weeks later, time them again. Sometimes I ask my patients, how many times do you have to rest before you got to my clinic from the parking lot? Or when you're walking in the mall with your family or your husband or wife or kids, how often do you need to sit down and rest? And you know, even though they may be walking fast, they still have walking fatigue. And you know, trial Fampira is relatively safe, easily tolerated, and a lot of times patients will tell me they feel better. It gives them a little oomph to their walking. How about the spasticity? How do you manage the spasticity? As I told you, this is hypertonicity of the muscle. Patients will tell you it feels tight, feels like something's pulling or tugging. It's chronic ache, and this is a result of demyelination in your descending CNS pathways. Different muscle groups are involved depending on the lesion. Spasticity may increase over time without any new CNS lesion. So that's why people with MS, lack of motion, decreased range of motion can cause muscle stiffness. You can get contractures or decreased tendon, or the tendons short, and this results in increased resistance to stretch. You got increased reflexes, uncontrolled spasms, limited mobility, increased energy expenditure, and overall pain and discomfort. So what's a way that you can evaluate for spasticity? You've got the modified Ashworth scale. 0, it means there's no tone. 5, 4 means you got basically your legs or arms are rigid, lead tight. You can't move it. How do you manage it? You've got your non-pharmacologic, your pharmacologic, and you have your surgical. For your non-pharmacologic, you can try stretching, positioning, range of motion exercises, orthotics like an AFO if you have a foot drop, physiotherapy. For your pharmacologic, you know, you got baclofen, tizanidine, gabapentin, Keppra can sometimes work, diazepam or Valium, and then finally Botox. And when all else fails, you can try a baclofen pump. So how do you manage the non-pharmacologic managements? They're easy. They're easy, benign, safe, and really anyone with MS should be doing them anyways, just to maintain what they already have and prevent loss, but also you may get some improvement. Now, when we go to this pharmacologic, we have different treatments. Commonly, I like baclofen. It's a cheap, easy drug. It works relatively well. Usually start with 5 milligrams. You can do 5 milligrams twice a day. You can go up to 90. Baclofen will work. If you give it enough to anybody, they will get weak and they will get kind of floppy, kind of like spaghetti. The problem is they may get too weak, and the problem is it's not a focal treatment, so you're going to get widespread. The good muscles are going to get weaker. The bad muscles are going to get weak as well. And it can cause drowsiness. And you don't want to discontinue it too suddenly because you can get disruption, seizures, hallucinations. Tizanidine is another centrally acting alpha-2 adrenergic agonist. You start low and go slow. You start with 1 to 4 milligrams if possible, and you initiate 1 to 2 milligrams QID. And you can go up to 36 milligrams a day. Again, you get sedation, hypotension, weakness, constipation, and dry mouth. It's a very good drug as well, but I don't use it as much just because baclofen does work very well. So I tend to use a lot of baclofen for spasticity. But you do got to watch the LFTs and CBC evaluation. What are your other pharmacologics? You can do benzos, Valium, clonazepam, Rivotril, or Valium diazepam. Very good. They will relax, but the problem is it's a focal. You do get used to it, so the drug that wears off over time, especially the more shorter acting the drug, the more you're going to need with time. Clonazepam has less of that problem. Diazepam has less. It has a long half-life. But you got to also keep an eye for sedation and dependency. Gabapentin works very well, but you get the sedation problems as well. But you may be hitting two birds with one stone with gabapentin. It relaxes you, but it also decreases the pain. And finally, when all else fails, you can try a baclofen pump. Now, baclofen pumps are not offered at every center. You need a neurosurgery specialist who's trained to give it. You need a good rehab doctor who knows how to program it and follow it. And so we don't have a baclofen pump at my institution, or we don't have anyone to install it. So my experience with baclofen pump is very limited. But one of the good things about the baclofen pump is that you reduced overall sedation. That's from when I was a resident. I remember we used to use it quite often. How about the tremor? The tremor is caused by lesions in the cerebellum or its pathway. You can get the head tremors, limb, trunk, eye, and speech. You can get this head titubation where their head kind of switches. And it's extremely difficult to treat the tremor. Very embarrassing and probably the hardest symptom to treat. But how do you try to manage it? You try to promote proximal stability, self-care strategies, increase weight-bearing activities. You can try some pharmacologics. You got your benzos, clonazepam. You can try your GABA receptor antagonists like gabapentin. You can do your phenobarbs like primidone. Beta blockers sometimes work, but again, they all don't work very well, and the side effects may outweigh the benefit. And finally, you can try DBS. I don't have a lot of patients who have cerebellar tremors from MS who've gone to DBS. Thank God for that. Fatigue. Fatigue is the most common and disabling symptom of MS. Almost 95% of people will have fatigue. And the thing about MS-related fatigue, you see it across all range of disease, no matter how severe the disability or how mild it is. People with MS will complain, and it can be the most troubling symptom in up to half of patients. And the fatigue is out of proportion to the activity that they're doing. And some evidence suggests that this lesion may be due to a basal ganglion lesion or in the hypothalamus. Now, what are the characteristic features of MS-related fatigue? This overwhelming sense of sleepiness, constant sense of tiredness, no energy, exhaustion, not related to the level of disability or to the work you're doing. And it may affect their motor function, can make them more tired cognitively, so they're not thinking as well. And we don't really know why you get it, but it's probably the most worrisome, bothersome symptom that all my patients complain about. Now, what are the causes of fatigue? Now, we know fatigue is identified as a significant problem, but you have multiple reasons. It could be MS related. It could be due to poor physical health. It could be due to lack of sleep. It could be just normal fatigue. You're just out of shape. And that's something you got to tell your patients. It could be due to the environment, visual, social, cultural. And then finally, depression can cause fatigue. So yes, fatigue could be related to MS, could be related to just normal quality of life, but you have to look at other causes as well. How do we assess it? You've got different fatigue severity scales. The fatigue impact scale, the modified impact scale, fatigue descriptive scale, and the fatigue scale of motor and cognitive functions. How do you manage it? Exercising is important. Get those weak muscles stronger and the stronger muscles even stronger. And you look at secondary causes. Cooling techniques. Fatigue could be related to heat exhaustion, especially in the UAE where it's thought to have temperatures of 50 degrees. In the summertime could definitely increase your fatigue. Teach your patients energy conservation, help them divide up their day throughout divide their tasks throughout the day. Don't use all your energy at once, as well as stress management skills. When all else fails, what can you try? You try medications. Amantadine, very safe, very easy drug. I don't think we know how it works, but usually 100 to 200 milligrams a day tends to work. It's not a very strong, potent drug, but when it works well, and the side effects are low. Provigil, I use a lot of it. It's a very effective drug. 300 milligrams, take it in the morning. Don't use any caffeinated or any medications that will increase your heart rate, because patients will feel this palpitation or anxiety. They can get headaches, migraines, a little bit of nausea, but it works extremely well. And if you start low and go slow, the side effects seem to be tolerable. You can try methylphenidate. I haven't used that. I haven't used methylritalin since the days of sight, because Provigil works so well. And dexedrine, we do not have dexedrine or dexamphetamine in UAE to try for MS-related fatigue. It's an amphetamine derivative. We don't have it. So at least we don't have it in the world of neurology, MS neurology. What about cognition? I'm almost out of time, so I'm going to even talk faster. Cognition and MS, cognitive impairments may be detected in 20 to 30% of patients at the time of diagnosis. Almost half of people will demonstrate cognitive dysfunction at some point in their lives, and 10 to 15% will experience decreased job performance or altered social skills. The prevalence increases with age and the duration of MS. Okay, now, what are the characteristics of MS cognitive dysfunction? Does not correlate to physical disability. It could be subtle, as I told you in the very beginning. So keep an eye on it. Ask your patients, are they forgetting things? Do they need reminders? Are they having difficulty balancing their checkbooks or paying bills? It could be under-recognized by family, friends, or employer. And usually it's not, deficits are not diffuse or global that we see in Alzheimer's. It could be just very subtle and very focal. What are the prevalence? Memory is commonly 30%. Information processing speed, about a quarter. Problem solving, visual spatial, as well as verbal fluency. Now, what are ways that we can assess for cognition? You've got the SDMT, the Symbol Digital Modality Test. Extremely easy, extremely fast. You can do it in the clinic. And the nice thing is you can follow it. You've also got the California Verbal Learning Test. We don't use that at SSMC. The SDMT is a lot easier, and I have more experience with that. What are the non-pharmacologic treatments of this cognitive dysfunction? Discuss the problem openly, including family, friends, or significant others, because the patient may forget that they have a problem, so they can't really talk about it because they don't remember it. Counseling, psychotherapy is important. Cognitive rehab for coping or compensatory strategies. And then finally, physical occupational therapy for safety strategies and environmental modifications. Now, sorry, okay. How do you manage it pharmacologically? DMDs are ideally DMD therapies to slow disease progression may affect cognition or slow brain atrophy. As Dr. Maya just said, when we looked at ponesimod decreases brain atrophy. So if you're compared to teriflunomide, so if you have less brain loss, you have more memory. So that's another way of looking at it directly. Medications to slow cognitive dysfunction or help prevent progression have not been shown to be effective for MS. So like your Abixas or Ariceps don't work. And now pain. Okay, 1 minute. Because of the time. Sorry, this thing opened up again. So pain is very common with MS. We almost got around 29 to 86%. And more than 50% of MS patients find pain to be problematic. And nearly 30% is underreported. What are the risk factors? Older age, longer disease, more severe disease, men and women are equally affected. Progressive MS seems to be higher, and it gets worse with depression. Pain subtype, you got different types. You got the continuous pain, you got the intermittent pain, you got musculoskeletal pain, and then you can have a mixed neuropathic and non-neuropathic pain. What are ways to treat pain? We already spoke. You've got Neurontin, Tegretol, amitriptyline. You can use it for fatigue, or you can use it for spasticity. You may use it for bladder dysfunction, and you can use it for pain. What are other treatments? Misoprostol and Topamax as well. Just keep in mind the side effects. Lyrica works very good for pain as well as Cymbalta. Cymbalta, I like it because you get the double-edged sword. You get the pain, but then you get the depression as well. Lyrica is good for the pain, the pain, the pain and the spasticity. How do other treatments? Stretching is good, massages, distraction, acupuncture can work, pain management programs, cooling therapy, as well as exercise and physiotherapy. Sorry, a lot of information on MS. MS, finally, I'm going to talk about depression. There's 50% of people with MS will get depression in their lifetime. And the incidence of depression is 3 times greater than the general population. And the etiology is unknown. It could be related to MS pathophysiology, could be used due to the meds, and it could be a problem challenge of living with MS. The presence of depressive symptoms does not correlate with severe disability. And suicide has been shown up to 15% of people with MS. Weak association may exist between depression and DMTs, fatigue, psychomotor retardation, poor concentration, poor sleep, appetite disturbance, all may overlap between major depression disorder and MS. And then finally, MDD considers to be an under-recognized, under-treated part of MS. How do you screen? You've got different screening tools for MS, for depression. What are the symptoms? Feeling sad or empty, irritable, crying most of the day, loss of energy, no interest and pleasure in the things that used to make you happy. You may have a decreased appetite or increased appetite, poor sleep, different sleep, decreased sex life, strife, and finally suicidal thoughts. How do you manage it? You want to provide a supportive therapeutic environment. You want to look at risk factors. You want to combine psychotherapy with antidepressant. Exercise helps. Be alert for suicide ideation, and assess and reassess continuously and adjust medications appropriately. And in regards to depression medications, you've got your SSRIs, and you have the SNRIs. I'm not going to talk about that in detail. Just know they work. They do have different side effects, and depending on whatever one you like to use, just use it. I like Cipralex, and I like escitalopram, sometimes Anzola. And it's mainly due to copay, what's covered on the patient's insurance. But they all tend to work very well. Just keep in mind side effects, the nausea, the metallic taste, and diminished libido. And with that, thank you very much. I went over a little bit on time, but I'm going to blame technical problems. But thank you. Dr. Osama, the floor is back.
You were always on time. You know, it's just, you took 32 minutes despite the interruption, so no worries.
Thank you. Good. Yeah. Excellent. Thank you.
We truly appreciate your amazing presentation and your vast knowledge and experience in the field, Dr. Shatila. We have a few questions. I will start with the first question. What is the most MS symptom that affect the quality of life in MS patient?
You know, probably I would say, well, there's a lot of symptoms I spoke, and I think the symptom that your MS patient has is the symptom that's going to affect their quality of life the most. But if you look at the most common symptom, it's got to be the fatigue. 90% of people with MS do complain of fatigue. So it's the most prevalent, the most common symptom, and a lot of people suffer from it and complain about it. But if they don't have fatigue and they have bladder problems, then that could be the most disabling symptom for that person. So everyone's different, but that's why you should talk to your patients and realize what's the most bothersome thing to them.
And does medication contribute to the sexual dysfunction, or it is really secondary to the primary disease?
Well, actually, that's an excellent question. Sometimes the medications we use to treat one problem can cause another problem. Like, we spoke about Flomax. Flomax is used for the bladder emptying. It relaxes the detrusor muscle. But then again, it causes retrograde ejaculation, so you get ejaculatory problems. You've got the SSRIs, great for depression, causes sexual dysproblem. You've got the benzos, you've got the Lyrica, good with pain, but causes fatigue, drowsiness, and makes your patient feel drunk. So again, sometimes one medicine, we're treating one side effect, we get another side effect from the medicine. So you got to use them sparingly. And that's why I think with every one of these symptoms, the most important treatment was exercising, risk factor modification, change your quality of life, and then go to medications if all else fails.
And speaking about side effects and fatigue, do you think caffeine would be indicated here to reverse the fatigue symptoms?
You know, the problem with caffeine is we're all addicted to caffeine, I think. And, you know, as you know, when you drink coffee every day, it stops working. So I think in the very beginning, if you're a caffeine naive person, you may get a little oomph or you get a little spark, but then you quickly get used to it and then the caffeine doesn't work. But then you get other problems. You may end up going to the bathroom more because of all the caffeine you're drinking.
Yeah.
So usually we say use it sparingly.
And, you know, antidepressants in MS, what is the ideal course of therapy? For how long you recommend antidepressants?
Well, usually with antidepressants, I mean, I look at the cause, but if there's no cause, psychology is very important. Seeing a psychiatrist, sometimes counseling, but usually I'll do a trial of 6 months of an antidepressant, low dose. I don't start high, you know, like 10 milligrams of Cipralex, 50 milligrams of Zoloft. Give them 6 months and we see. Now, if they failed that, then I send them to my psychiatry colleagues for some help.
Yeah, last question, if you don't mind, Dr. Shatila. What is the role of exercise for the management of MS symptoms?
Extremely important. Exercise is important, whether you have MS or you don't have MS. And, you know, it's one of those things that when all else fails, exercise is the treatment. It will help your insomnia, help you lose weight, increase your range of motion, increases your strength, builds your stamina. So whether you have MS or you don't have MS, exercise is probably the thing that we tell every one of our patients to do and do it often. We're all guilty of not doing it as much.
But what is the type of exercise, you know, is heavy exercise have any impact?
No, well, the best type of exercise for MS patients is the what do you call it? The aqua therapies, you know, swimming in a pool. That's probably the best because they don't feel the heat. It's good for them. And if you're going to do, you could try aerobic exercises, but always do what your body can handle. Don't overpush yourself. You know, problems with balance, people with balance may not be able to do free weights. They could do machines. They may be more sedentary exercises, but there's different types of exercises for different people. And even if you were just sitting and you could just move your hand, there's a
I think we lost you one more time, Dr. Shatila. Hussam, can you hear us or Maya?
Yes, I can hear you. It's,
yeah, no problem. No problem.
Yes, Dr. Osama.
Yeah, sure. Dr. Shatila, thank you very much. You know, sorry to interrupt you here, but there is another technical glitch. You know, we have to go to the second speaker. We appreciate your presence with us at all times, and we hope to see you in future events as well. Now it's my pleasure to introduce our last speaker for today. We have an amazing expert in the field, Joelle Massouh. Ms. Joelle is currently the clinical and operational manager of the Neurology Institute and MS Center at Harley Street Medical Center, Abu Dhabi, UAE. From 2011 until May 2021, she was the nurse in charge of the MS Center at AUB Medical Complex in Beirut, Lebanon. She is the first nurse and healthcare professional in the Middle East to be double certified as an MS certified nurse by the MS Nursing International Certification Board, and as multiple sclerosis certified specialist by the Consortium of MS Centers. Ms. Joelle is a member of the International Organization of MS Nurses, a board member representing the Middle East on the MSNICB, and the Menactrem's Nursing Program Coordinator. In 2019, she was awarded the inaugural International MS Nursing Leadership Award by IOMSN at the annual CMSC Congress in USA. So now I'll leave the mic and screen to Joelle to speak about the role of the multidisciplinary team in multiple sclerosis. Joelle?
Thank you, Dr. Osama, for the beautiful introduction. So in the interest of time, I would start with my presentation. And after hearing from several experts, namely neurologists and pharmacists today, our colleagues who are specialized in MS, I'm going to wrap up by talking about the MS multidisciplinary team and the importance of a team in taking care of MS patients.
Just a reminder, it's a 15 minutes presentation.
Yes.
Thank you.
So, of course, MS is a chronic disease. It's a disease of the central nervous system. It's also the leading cause of neurologic disability in young adults. And it occurs at a time where there's peak career and parenting years. So at a very important, crucial time in the patient's life. 50% of our patients, the onset of the disease will be between 20 to 40 years of age. And this is why our patients will live the majority of their adulthood in the presence of the chronic illness, which is MS. It can really impact all aspects of individual and family life. We have to remember that the course of MS is mostly marked by uncertainty. We do not know when patients will have a relapse. We put them on therapy to avoid relapses and to prevent relapses, but it is still marked by an element of uncertainty. Understanding these things will help us understand why we need a team to take care of our MS patients. So there are many advances that has happened in the last decades, 2 to 3 decades in MS since the onset of disease-modifying therapies. But still, there are also many challenges as well. MS till this point is incurable. It is treatable, but it's incurable. It can produce numerous symptoms, and as Dr. Ahmed just discussed, and in some cases, without the proper management, without the proper follow-up, it can result in a degree of disability or a significant disability. So our ultimate goal is to really approach MS in a multidisciplinary fashion. Effective MS management will only occur through comprehensive care by minimizing relapses, by decreasing disease progression or preventing disease progression, by also treating symptoms and addressing the patient's functional limitations. We do that through a set of pharmacologic and non-pharmacologic interventions, most of which Dr. Ahmed went over already. So we need an integrated multidisciplinary team approach to maximize outcomes in MS and to maximize quality of life for our patients. So who is on the MS treatment team? What kind of experts, what kind of specialists should be on the team? Of course, by default, a neurologist, and preferably an MS specialist. There's also the MS nurse, a pharmacist specialized in MS, and then we can add other specialties depending on each patient's case. So urologists, neurosurgeons or pain specialists, physical and occupational therapists are also very important, psychiatrists, psychotherapists or psychologists, and specifically neuropsychologists, social workers and care managers, and a speech-language pathologist in certain cases. So as we can see, no single practitioner can address all of the problems potentially created by MS. So to start off with, my specialty, so the role of the MS nurse. Originally, the relationship in MS and in many other diseases between the patient and the doctor was purely like a linear relationship. But to complete this practice, to complete this circle or cycle, MS nurses have a vital role. And this is how we complete or help really fulfill this cycle, this relationship between patients and doctors, to avoid that relationship being purely paternalistic with the doctors dictating what the patient should do. It should be a back and forth process, and the MS nurse should have a major role in it as well as members of the multidisciplinary team that I will go over in a few. So what can be some of the roles the MS nurse can cover? She's definitely a great listener, a mediator of this relationship, a guide for the patient, and an advisor as well. Of course, through the International Organization of MS Nurses, we've developed the role of the MS nurse since many, many years. There's a philosophy and a definition behind what an MS nurse should be. And this nurse will shape the course of the disease by facilitating treatment, aiming to interrupt acute episodes such as relapses and delaying progression of pathology, all to facilitate the management of MS symptoms. So MS nurses enhance and promote safe, maximal, and where possible, independent function. So our hope is to maintain the patient's independent function as much as possible. This should be our ultimate goal. Of course, the MS nurse is a competent expert who collaborates with those affected by MS, and of course shares knowledge, just like we're doing today, shares strength, and shares hope as well. That's very important. There's a philosophy of hope and the wellness strategy behind the role of the MS nurse. She can also enhance adaptive and coping skills, facilitate empowerment. So we want our patients to be empowered and have autonomy and have a sense of control, because losing control or the feeling of losing control is very detrimental for our patients. It really puts them behind and will affect their mood and will affect their ability to control their disease. What we also do is try, as I said, to engender hope and increase positive attitudes among those affected by MS. Of course, we've also developed a model of nursing care in MS, and that model goes all through the different disease course of MS, from new or probable MS to relapsing MS to progressive MS and to very advanced cases of MS. We do that through several, under 3 big umbrellas. The first is establishing care. We build a relationship with our patients, open lines of communication, build trust. So one of the most fulfilling things I can hear from my patients is when patients tell me or my colleagues, other MS nurses, that we trust you, we trust your opinion, because you have consistently showed us that you're guiding us to evidence-based strategies, you're telling us what might happen, how we can handle our symptoms. So trust is very important. Sharing information with our patients, assessing, baseline assessment of all our patients' functions. So in addition to some of the strategies, such as the neuro exam and other assessment techniques the doctors will use, nurses can also participate in that, and we can add by doing specific tests in MS, which we call the MSFC, the multiple sclerosis functional composites. Another umbrella is the continuing care, and here we really focus on education, both for the patient and the family, around DMTs, around symptom management, around side effect management of drugs as well. We encourage self-care strategies, and we assist or refer to handling vocational issues. A third and important umbrella is sustaining care, and here we need to sustain the care of our patients as they evolve through the disease by maintaining their well-being, by coordinating all needed referrals, because our patients are not isolated MS patients only, they will have other issues to deal with as well. We also will identify community resources important for referrals. We will advocate for and help ensure a comprehensive MS care for our patients. The 4 domains of MS nursing practice are clinical practice, advocacy, really advocating for our patients, education, and last but not least, research. Involvement in research, being a member of national and international organizations. Because nurses are on the bedside, they really can come up with very important research questions as well. So some of the advantages will include providing time for patients more than other providers in certain instances, of course, establishing a trusting relationship. We do have a critical insight into our patients' everyday life. So we have to really use that insight to help our patients. And we do employ a holistic approach to our patient needs with a greater emphasis on health-related quality of life. Of course, the nurse is a vital part of the MS team, but definitely along with other members of the team, she will utilize critical thinking to follow the nursing process from patient assessment to diagnosis of the problem, to planning and intervention, implementing that plan, and most importantly, evaluating outcomes and changing the plan accordingly. I really like this quote that helps us really wrap up the role of the nurse and really trying to help our patients find a place for the illness while keeping the illness in its place. Now to move on to a very important role as well in the team, and this is the MS pharmacist. This role has grown over the last few years. In the region, I would say it was definitely modeled by my colleague, Dr. Maya Zainuddin, who is the first MS pharmacist in the region. but also internationally, the role is improving in MS centers in the world, especially in North America. Pharmacists are becoming more and more part of a routine MS team. What are some of the things MS pharmacists can do? So definitely they can present DMT options to patients so that patients are allowed or are empowered to make an adequate, informed choice. They can train patients on medication administration, on side effects of medications, on special handling of certain drugs. Compliance and adherence are very important points that pharmacists can educate patients on the importance of adherence. Effective management of adverse events. So we know a lot of times our patients will discontinue drugs because of their adverse events. And here the role of the nurse, the pharmacist, through telehealth nursing or telehealth communication, or specifically face-to-face interactions with our patients, can really help in keeping patients on drugs by handling these adverse events. And of course, promoting adherence as a consequence. Now, how do pharmacists help in treatment decisions? They consider the benefits and the risks, and they really target all of these categories to help patients make better informed decisions and really stick to their treatments. So they tackle mechanism of action with patients. Our patients are becoming more and more educated, informed. They read a lot. They have access to lots of online resources, and thus they really want to know sometimes, of course, I'm not generalizing to all patients, but a huge proportion of our patients really want to know how does the disease-modifying drug work, what is it doing to them on a cellular level. So we explain, of course, in simple terms, depending on our patients' backgrounds. And the pharmacists can really help in that a lot, because neurologists will not have the time and will also not have maybe all of the time the proper maybe language to help patients understand mechanism of action and everything else. So they employ an evidence-based approach. They will also discuss safety with the patients, tolerability. So they will explain side effects so that patients are not surprised. Convenience. So also, just like the nurses, the pharmacists will be aware about their patients' daily lives a lot. They become more and more involved, and thus they are able to know which patient has would fit which treatment better, depending on convenience and all of that, lifestyle and everything else. Monitoring. So pharmacists are highly involved as well in how we monitor monitoring parameters for drugs, such as following up on liver function tests, white count and lymphocyte count, and all of these issues. They're also highly informed and involved in pharmacoeconomics, so cost of drugs, third-party coverage, and all of these issues as well. They really know patient preference, and they can be able to advise patients depending on their preference. And they're highly also involved in pregnancy issues that come into play when we decide on treatments and when we put a pregnancy plan with the patients as well. Now, to move on to other specialists, such as the physiatrists or the rehab physicians and physical therapists and occupational therapists. So here they are highly involved in two big categories: the spasticity assessment, and here they can use scales such as the Ashworth scale to be able to assess patients and follow up on them. And they can recommend and be involved in spasticity treatment. So of course, it's a multidisciplinary approach, as we mentioned in the previous presentation. Treatment should be initiated after a rigorous assessment and analysis, and we can employ methods such as pharmacologic and non-pharmacologic interventions. And as Dr. Ahmad mentioned, we also titrate in most drugs in MS. So we start at low levels to avoid side effects and up titrate to reach an optimal dosage. In gait disturbances, physiatrists are also highly involved in targeting walking impairment and all of the factors that affect walking impairment. So mobility and walking in MS is not just affected by simply motor power. It's not that easy or straightforward. There are lots of other issues: spasticity, ataxia, incoordination, visual disturbances that might be affecting mobility, muscle weakness, of course, sensory disturbances, so proprioception, we assess vibration sense, position sense, all of these affect walking as well. Cognitive deficits, fatigue, emotional and psychological problems. Of course, some patients need on their team a pain specialist or a neurosurgeon. We've heard a lot of the times before, sayings that MS does not cause pain. It's an outdated concept of MS would not cause typical pain like we know, but there are a lot of pain syndromes in MS that can be a direct cause of the disease itself. So, of course, they've been mentioned by Dr. Ahmad. So they go under neuropathic and non-neuropathic pain, and treatments really are targeted depending on the origin of the pain. And here, a pain specialist would really be able to help us in these treatment strategies, and a neurosurgeon as well, if we need to perform nerve blocks, radiation therapy, all of these issues. Very important to involve a psychiatrist and a psychotherapist in our team. Why? Because the percentages they speak for themselves. Around 50% of our patients will at some point of their disease suffer from depression. So this is a chronic illness, but as compared to other chronic illnesses, MS has a higher rate of depression, definitely. It can impact cognitive function, relationships, adherence to treatment. People will quit drugs if they are depressed, and quality of life, of course. So in a study on from Lebanon by Dr. Yamout and a group, predictors of quality of life among MS patients showed that all of these factors will affect quality of life, focusing on depression, the issues of depression and social support as well. Pharmacotherapy, of course, mentioned already by Dr. Ahmad, but to brush over these topics, SSRIs are probably very important in the management, and we can also employ CBT, cognitive behavioral therapy, as well. Why is a neuropsychologist also important as part of our team? Because of the issue of cognitive dysfunction. It can be present, as we said, in MS as early as the RIS stage, or the radiologically isolated stage. And this is why we need to assess cognitive function from the beginning. The most affected cognitive domain is information processing speed. And this is why for us, we use the SDMT, the Simple Digit Modalities Test, at each visit, or approximately 2 to 3 times a year. We repeat this SDMT test so that we assess our patient's cognitive function. If needed, we will refer to a neuropsychologist who will do more detailed evaluation of the cognitive deficits using more and more testing, and they can refer to cognitive rehabilitation programs wherever they are available. A urologist is also a very important part of our team, because over half of our patients will experience bladder dysfunction at some point. That can be a mix of urinary frequency, urgency, or urinary retention, or a combination of both. What does the urologist do? So first, as a team, our team, like the MS specialist, the doctor, the nurse, we can do the primary assessments and refer accordingly. The urologist will do a more detailed clinical assessment with urodynamics, and then they can employ or administer the best therapy depending on the origin of the symptom, from pharmacotherapy to Botox injections to a number of other therapies. And with this, I will wrap up and say that the it takes a village really to take care of MS patients. At the heart of this team is the patient and the family. This should be our center. And all of us as specialists should really have one thought in mind. Our team outputs should be to improve adherence, symptoms, help our patients adapt to the disease, and increase quality of life. And as we said, it cannot be done by one single practitioner. It has to take a team to be able to reach these outcomes. So thank you.
Joelle, thank you very much. That was an amazing presentation. You are an amazing speaker as well.
Thank you.
We sense your passion and expertise in the field, Joelle. We'll take one question. When choosing a new therapy for MS patients, what is the exact role of MS nurses and pharmacists in this regard?
Yes, definitely. So doctors will often either suggest or give multiple options for patients, or at least a couple of options. It's rarely ever a doctor giving one option to the patient in this really treatment era of MS, because we have so many approved drugs. And here the role of the MS nurse and pharmacist comes into play. It's very important because we will sit with the patients extensively and also explain everything about these different options. We will explain mechanism of action, route of administration, how this drug will fit into the patient's life, what kind of monitoring parameters they need to follow. And in this way, in this technique, we will be able to help our patients make the right choice for their life and their lifestyle.
Excellent. Now it's the, thank you, Joelle. Thank you very much. Now it's the time for case discussion. I will move the screen to Dr. Shatila again and Joelle as well. So it's a combined case discussion, as I understood. This will be like a 20-25 minutes case discussion. Dr. Shatila.
Okay, thank you, Dr. Osama. Let me share my screen. There we go. Hopefully we don't have any technological glitches right now. Don't know what's going on today. Internet's weird.
No problem. You know, we encourage all the audience to vote for the questions or to answer the questions. The poll will be shown by Hussam shortly. Go ahead, Dr. Shatila.
Okay. So I have two cases today. So here are my disclosures. So the first case, this is a 28-year-old male. Now, interesting thing is I saw him back in 2010, he was diagnosed with MS. I wasn't in the UAE in 2010. So he was diagnosed at an outside institution. He had optic neuritis, he had ataxia. I'm sorry, got IV steroids, got better, and was diagnosed with MS. Then around 7 months later, he was started on interferon beta 1A, IM. Back in January 2012, 6 months after that, he was switched to interferon beta 1A sub-Q, and due to walking difficulty, at the time he could walk 1 kilometer without assistance. Now, in December 2012, 12 months later, I saw him for the first time. When I saw him, he was ambulatory without assistance. He wanted to change his medicines because he was having needle fatigue. I requested MRI. I told him we'll check his disease activity. We discussed treatment options. And then he kind of disappeared up until 2014, so 2 years later. Not uncommon in Abu Dhabi. Our patients sometimes fall off the grid. So when I saw him again, February 2014, he comes to my clinic. I'm sorry, this camera. He stopped taking his medications. He wasn't following. I told him it's important to take medications. I discussed some options, and I told him to follow up. What happens? He disappears for another year. Comes back in March 2015. After disappearing for 1 year, he now comes with an ataxic gait. He's wide base, increased tone, and bilateral lower extremities. Since it's got weakness now in his legs, 4 out of 5 strength. And before he could walk a kilometer without assistance, now he can walk 25 feet in 9.5 seconds. Very slow, very unsteady. Again, I told the patient, you need to take medicines. This is urgent. Stop playing with your life like this. And obviously, it also became very obvious that he was a very non-compliant person and poor adherence. So this is his MRI back in 2015, just to give you an idea of what his brain looked like. So you look at the sagittal, and you'll see those whites. Okay. Now we go to the flare. All these little white spots, paraventricular, large volume, large ventricles, infratentorial spinal cord lesion. So he's got a significant amount of lesions. When we look at his spine, so in the spinal cord, he's got lesions that are very typical for MS. They're non-continuous. They tend to be peripheral. And, you know, as you can see on the right, that's where you see these non-continuous peripheral lesions. And on the right, you can see this hyperintense lesion. It looks continuous, but it actually isn't when we break it up. So now what medication Let me cameras. Okay. So what medication do you feel would be best for this patient? Now, I've already told you he was on interferons. He stopped 2 interferons. He doesn't follow. So what drug would you want to give him at this time? This is now 2015. So would you give him fingolimod? Would you give him DMF? Would you give him natalizumab? Would you give him teriflunomide, or would you go with alemtuzumab? Let's see. What does the audience say? Whenever you're ready, we can go to the polls. I just close it.
Hussam, are you going to show the poll, Hussam?
Yes, the poll is showing now.
It is? I don't see it. The answer is showing? I don't see them. That's weird. Oh, there we go. Okay, so 32% of the audience recommended teriflunomide. Not a bad option. Fingolimod is right afterwards. Then you got DMF and Tysabri tied. And the least popular was alemtuzumab. For me, honestly, I actually was going to start him on fingolimod at the time, just because he had already been on interferons, 2 interferons. And based on the Teneri trial, when they looked at interferons versus teriflunomide, both drugs were equal. So he's already failed 1 drug. The odds of him passing or being more effective on teriflunomide is going to be low, because it's basically they are just as good. So I wanted to go with something a little bit stronger, but not a lot of follow-up like natalizumab, and compliance was a problem. So I wasn't going to give him DMF because it's twice a day. So fingolimod seemed like the best option. Yes, it needs follow-up, but he can do it where he lives. So I told him, we're going to give you fingolimod. This was in 2015, and we went from there. So now what happened to my patient Mubarak? He comes back in clinic in 2017. He disappears for another 2 years. Now his EDSS is 7. He has truncal ataxia, dysmetria finger, nose finger. He cannot walk anymore. He's still got good strength, but now he's very ataxic, unsteady, cannot even walk more than a couple of meters without falling down, and his toes are up going. So unfortunately, I got to see this person progress over the years due to his non-compliance, poor follow-up, and it was sad. That's when I finally told him, look, this is what I kind of yelled at Mubarak. I told him, you need to do something. And this was his MRI at the time in March 2017. This is GAD enhancing. He's got 1 lesion. Where is it? Okay, I'll kind of light it up right now. Okay. He's got 1 lesion right there on the right hemisphere. So he's got active disease still. So now what's your concern for your next step for this patient? Is it the lack of compliance for taking medications? Significant accumulation of disability within 3 years, lack of effective response to interferons. He lives 280 kilometers from the hospital, or is it all of the above? So what do you think is the most important thing that's going to help guide your physician treatment? And whenever you're ready, I'd like to see the answers. Do I just close my thingy? There we go. So whenever the answers. Okay, so all of the above, 50%. Actually, it's true. They're all very important things, because his lack of a compliance taking medications will definitely limit what you're going to give him. He's had significant disability in 3 years. So you want to give him something effective but safe and will work. He also didn't respond to interferon, so I'm not going to go back to the same medications that didn't work. And he does live 280 kilometers, so I don't want to give him a monthly medication like Tysabri, because again, it's got to be given at SSMC, and it's about 4 hours away or 3 hours away where he lives. That's going to be very burdensome. So really, all of these are very important. So now what medication would you give the patient? So now we're in 2017. Is it still fingolimod? Would you give him teriflunomide? Would you give him natalizumab, given that it needs to be once a month? Would you go with ocrelizumab or DMF, which is twice a day, or now would you consider alemtuzumab? Whenever we're ready, we can see the answers. So when I'm looking here, this is interesting. Natalizumab has the highest at 24%. It's an excellent drug, but again, for me, natalizumab, I didn't choose natalizumab because it was a once a month infusion medication. He's already proven to me that this guy disappears. Every time I saw him, he would go for 1 or 2 years, sometimes a year. So follow-up for Mubarak is horrible. So I don't know if he would come every month for natalizumab, and then you run the risk of rebound if you stop it. Alemtuzumab has 15%, very effective drug, but you need your patient to show once a month for your thyroid, once a month for your CBC, for your urine analysis, and every 3 months for thyroid. He's not going to show up every month for blood tests, so that was off the table. DMF is twice a day. I have a hard time him even taking his medicine once a day, maybe. So I was very hesitant about DMF, and he's got a very aggressive disease. Fingolimod was good back then, but at that point in time, I thought, again, now we had a medication that was a little bit better, and I gave him ocrelizumab because it was twice a year. So what I did was I gave him ocrelizumab, and this was, so he received his first dose of ocrelizumab in 2017. He had received 9 doses of ocrelizumab up to like 6 months ago, and then again, Mubarak disappeared. He stopped taking medicine. So even ocrelizumab, while it was good for almost 3-4 years, 5 years, he finally got bored and he stopped. Sad, I've been calling him up, but how did he do in those 5 years? This has dysarthric speech. He does have some left upper extremity sensory loss. He does have some mild dysmetria on fingernail's finger, but what's the difference now? He's now walking 25 feet in 6 seconds. And the MRI shows regression of the previous enhancing lesions in his frontal lobe. So his MRI got better, he physically got better, and he's doing well, but now he doesn't want to take his medicines anymore. And now this is unfortunately one of the sad things and I'm trying to have him come back to continue his meds. What's his MRI? The MRI on the left is the new one, the right is the old one. If you look at that lesion you see it's no longer present, that is gone. The right is the old, left is the new. You'll notice that you'll see that some lesions have disappeared, some lesions have gotten smaller. So his brain did well. He actually did very well. And hopefully he comes back. And this is the lesson. Basically, there's reduction in all his periventricular lesions. He's doing very well. Even the brainstem lesions have gotten smaller. There was a lesion in cerebral peduncle, that's gone. So there's significant improvement in his brain. So hopefully he comes back. Do I have time for case 2, or do we call it case 2? I'll be very fast. Case 2, this is a 29-year-old male with MS since 2013. He was complaining of fatigue, stiffness, numbness, and on his left upper extremity, MRI of the brain consistent with MS. Initially, we started on Tecfidera 2014, and he stayed until 2016. No symptoms, and his MRI was stable, but then he had a relapse in 2015 with paralysis of the lower extremity that did recover. He stopped Tecfidera for 1 year in 2017, and because it was non-compliant and his symptoms got worse. The fatigue, the neuropathic pain in his legs got worse as well. He got an MRI in 2018. The MRI showed increase in brain lesions, and this was attributed to non-compliance. And he was reminded of the importance of medications was followed. Currently, he's taking Tecfidera, Lyrica, Tramadol, clonazepam, and Vampira, all for symptomatic management. Now, in March 2019, he's deteriorating. His balance is more affected. He can't walk normally. He's dizzy, got blurred vision. painful tingling in his body. He's been to the ER, they didn't find any infections, and he got steroids and he improved. Normally he walks independently, but the MS now is affecting his fatigue. He needs to use a cane for balance. When I saw him in August, he's JCV positive, very highly positive. He had 2 attacks in 1 year, I told you. 1 MRI, 1 clinical, and then in the medications, this time he was compliant. So the first attack was non-compliant. Then he was compliant. And then he had another radiographic lesion after that. And then he had a physical attack after that. So he's had 2 attacks, and within a year, he's compliant, aggressive disease. We discussed risk and benefits of different medications, and we did blood work just to decide. This was his MRI in 2019. He's got a relatively large GAD-enhancing lesion. He also had a large GAD-enhancing lesion in the cerebellum. Look at his brain, large tumefactive lesion, as well as multiple periventricular lesions. He has a large lesion load. So what medication would you give for Sultan? If we go up with the question. Natalizumab, fingolimod, DMF, ocrelizumab, cladribine, or alemtuzumab. Whenever you're ready, we can. Show the answers. Okay, so when we look at the answers, natalizumab was number 1 with 24%. But you have to remember that his JCV index was 3.6. So he has a high risk of developing PML. So that kind of was a deterrent for me to start on natalizumab. Fingolimod was the second with 24%. That was good. But one of the problems with fingolimod and DMF, there is a study where they looked at DMF and fingolimod, and they appear to be just as good. Maybe fingolimod's a little bit better, but the study showed that they were equally effective. It was open label, it was real world, it was MS-based. So it's not head-to-head, but it does appear that fingolimod may be just as good. So I was a little bit hesitant to go with fingolimod because he's already failed DMF. Ocrelizumab is an excellent choice, actually. I think Ocrevus would be very good. Every 6 months, he does it. I've already shown you in the last presentation, it's highly effective. Cladribine is an excellent option, actually, but you got to remember this is now 2019, and cladribine, or my first patient on cladribine was in April 2018. So I didn't have a lot of long-term data on cladribine other than the first 4 years that was shown in the Clarity and the Clarity extension. Alemtuzumab, even though it had the least, alemtuzumab I felt was highly effective. I did have long-term data. He was now more compliant. Initially he wasn't compliant, but now he was becoming compliant because I had at least almost a year and a half of compliance. It is highly effective. We have long-term data. And this goes to the idea that Dr. Reem was talking about, induction versus escalation. Would it be better just to give him something extremely potent now and potentially quiet down his immune system? Or do you go an escalative approach? So what did I do? I ended up giving him alemtuzumab. He got alemtuzumab in 2019, and then he got another dose in August 2020. I gave him his pre-medication. It was a program by Sanofi where they come to his house, check the blood, check the urine. This was recent. This wasn't during Mubarak's time. Maybe Mubarak would have been a lemon. But again, he's been doing well since then, and he has no problems, no side effects, no relapses. And this is a picture that Mubarak sent me a couple months ago, basically saying that his collections of canes have gone dusty thanks to me. I think it's more thanks to his support and his perseverance and his stubbornness to be better. His MRI's gotten better. He now no longer uses a cane. He's stable. He hasn't had a relapse in almost 4 years now, or since 2019. He's doing amazingly well. So induction can work in some people. Yes, it's a very burdensome medication, but when it works amazingly well. And it can work, and it's, for some people, it's a really good medicine to use. So with that, I will finish my presentation. Thank you all. should we go?
Yes, I will.
Joel, you are next, or
I'm going to share my presentation.
Go ahead, Joel. Thank you. Thank you, Dr. Shatila.
So we'll start off with the first case, a 59-year-old male who has been treated with a disease-modifying therapy for 7 years. He previously experienced 1 to 2 relapses annually, and this has been reduced to less than 1 per year. He stopped working 5 years ago. He currently lives alone and no longer drives. He complains of short-term memory problems and difficulties with activities of daily living. So the patient calls the MS center on a Friday morning requesting a referral to a dentist. He states that he has had facial pain for about 1 week and needs to see a dentist. So when questioned by the nurse, it was determined that the pain emanates from his ear to his chin and is worse at night. So we'll start with the first question. What is your plan of care for this patient? Would you refer the patient to a local dentist? Would you prescribe an NSAID, PRN, and advise the patient to rest? Would you schedule an immediate follow-up visit with a full neurologic examination, or would you schedule a cranial MRI? Okay, so most of you did answer correctly. The next step would be for us to schedule an immediate follow-up visit for a neurological exam before we know whether we need to refer the patient or ask for an MRI or not. Now, 3 months later, this patient is seen in our office anxious, looking unkempt. He stopped his medication because he can no longer afford it. And he has bruises on his knees, although he denies falling. He holds onto chairs or any other furniture for ambulation. What is your plan of care for this patient? Would you arrange for transport to the ER? Would you refer the patient to a local community agency for social service and rehabilitation evaluation? Would you schedule a visit with a neuropsychologist or restart disease-modifying therapy? So answers are a bit split as I see. So some of you answered that we should schedule a visit with neuropsychologists, but the more appropriate answer here is to refer the patient to local community agencies, a social service or social worker for rehab evaluation. Now, why would we do that? Because the concern of this patient here is that we might be having frequent falls. He might need some assessment, some help in his home, as opposed to the need for a neuropsychologist at this point. So the neuropsychologist is more, as I mentioned in the lecture, is more targeted towards cognitive issues, information processing issues, and we will base that based on our assessment and whether the patient needs help in cognitive issues. Now, in general, I want to ask you as well, the cognitive impairment in MS can result in what? Deficits in long-term memory, alteration in executive function and information processing, worsens with age, and improves with stimulation and rehabilitation. So remember, we want the best answer here. So most of you answered improve with stimulation and rehabilitation. So while we eventually want to refer patients to cognitive rehab based on their cognitive assessment. But the more appropriate or better answer here is alteration in executive function. And this is the main issue in cognitive impairment in MS. It's the problem in executive function and specifically information processing speed. So this is the best answer in this case. So in the interest of time, I will skip this case and go to the last case. So Joanne is a 42-year-old married mother of 2 school-aged children. She works full-time as a real estate agent. Now, she has a very busy schedule. Her day starts at 6 a.m. As a mother, she prepares lunch for children, gets them ready for school, and prepares dinner in a slow cook, like crock pot. Her husband takes the kids to school. Her appointments start at 9 a.m. She goes back and forth showing houses as a real estate agent. She arrives home at 2 p.m. and then goes for a 30-minute jog. Then she picks up her kids at school and takes them to after-school activities as well. And she tries to be home by 6 p.m. for dinner. Now, she was diagnosed with RRMS 4 years ago after an episode of optic neuritis, following a period of training for a marathon. So she was started on an injectable DMT at diagnosis. She remained relapse-free with no major changes on MRI, but because of injection fatigue, she requested changing to an oral therapy. So she has been stable on fingolimod for 2 years without relapses or significant MRI activity. Now she's presenting because she is just not feeling well. She complains that she has no energy after work and school pickup. She is slower when jogging. She notices her legs are fatigued. If she has any evening appointment, she cannot feel up to it. She's not cognitively sharp to do it. Eventually, she started drinking more and more coffee throughout the day. And we mentioned coffee before when a question came up, and Dr. Osama discussed that. She has to stop frequently to use the restroom. She's not feeling like she empties her bladder completely. And because of this, she is restricting water intake. She finds herself tearful, agitated, and she really expresses to us that this is not like me. So what factors might be having an adverse effect on Joanne's bladder issue? Running in the afternoon, increasing caffeine and restricting water intake, feeling tired and agitated, or failure of her disease-modifying therapy. So what is the factor mostly impacting negatively her bladder issue? So most of you answered increasing caffeine and restricting water intake, and that is the right answer. Caffeine can be can help a little bit in the beginning, like Dr. Ahmed said. We sometimes recommend for our patients to have a little caffeine or stimulants in the afternoon in certain doses and low doses, but eventually they stop helping and they can really affect, as a diuretic, they can worsen our patients' bladder symptoms. And we do not want patients to restrict water intake. And this is what's happening in her case and worsening actually her symptoms. Now, sorry, I can see that. So keeping in mind the overall symptomatic picture, what would your advice be to help Joanne conserve energy? Run at the best time of day for her, get 8 hours of sleep, and arrange carpooling after school. Run in the morning when it is cooler, continue to drink caffeine throughout the day for energy, since she doesn't want to take medications. Behavioral measures don't help conserve energy. She needs to be convinced to take medication and supplements for energy, or fatigue could mean that her DMT is not working, an alternative should be considered. So answers are a bit split, but you guys still got the right answer, which is for this patient, we need to see what is the best time of day for her to do her exercise. So she has to select the best time. She should be getting better sleep, 8 hours of sleep. And we can consider things that can help conserve her energy, such as asking for help in picking up her kids after school. So it's very important to encourage our patients to ask for help as well. Now, she's made some changes. She streamlined her life, made her schedule easier. She's maintaining 8 hours of sleep. She decided to jog in the morning when it is cooler. And after these 6 weeks of consistent behavioral changes, she noticed an improvement in her fatigue. However, she still feels irritable, and she really expresses that I feel like this is not like myself. So at this point, what would you recommend? Would you put Joanne on an antidepressant? Would you screen for thyroid dysfunction, vitamin deficiencies that might be associated with mood changes? Recommend counseling while waiting for these test results? Would you suggest that it may be time to start training for another marathon while she still can? Or would you talk to Joanne about disability? Okay, I'm happy most of you answered that correctly. And the rationale for this is before we jump into treating issues such as depression or fatigue or multi-symptoms in general, we need to look for any multifactorial reasons. So definitely screen for thyroid dysfunctions. Thyroid disorders, hypothyroidism can be associated with depression. Screen for any issues that might be really affecting her mood changes. And meanwhile, we can recommend some counseling if needed before we decide to treat, because if there are reasons or deficits that might be treated, such as hypothyroidism, we can work on that before trying to treat the depression. So it might be caused by something other than MS specifically as a primary reason. And what plan for symptom management would work best for Joanne after you heard all what we mentioned about her? Would you develop a concrete plan of action for managing fatigue with behavioral changes, for what to do if it is ineffective, and schedule a follow-up appointment in 4 weeks? This is option number 1. Would you tell Joanne to do her best to slow down, take stress out of her life, and then see her back in clinic in 6 months for follow-up? Would you tell her to stop drinking coffee because fingolimod can cause significant blood pressure elevation? Joanne does not appear motivated. It would be best if she speaks with the healthcare team about long-term disability. So what is the best symptom management plan for Joanne at this point? Okay, so I see that most of you answered correctly. And to really wrap up in talking about the concept of symptom management, the best thing to do is always to have a concrete plan of action for our patients, whether it is for managing fatigue or other symptoms, with behavioral changes, with other pharmacologic treatments if we need. So we assess first, we develop a plan of action, we implement this plan of action. We also decide to evaluate. The most important thing is to evaluate, and we cannot do this in 6 months. It's too far along. So we should probably better evaluate in 4 weeks for this patient specifically, and then decide plan B, what to do, how to escalate if it's ineffective. So we evaluate our outcomes, and then we alter our treatment plan or our symptom management plan of action, care plan as needed. So this is why this is the best answer in this case. And with this, I will end the presentation, And we really wrapped up what to discuss and how to target symptom management in this talk. And I think I'm done, and I think we can check if we have questions for me or Dr. Ahmed.
Thank you very much. With this, we conclude for today. I would like to thank all the attendees, all the speakers, Dr. Reem, Dr. Maya, Dr. Shatila, and Joel for the amazing presentation. And I want to remind you that you will receive your certificate of attendance by email within a week from today. If you miss any part of this webinar or would like to revisit the lectures, you can check our IVPN Neuropsychiatry library at our website. Follow us on our social media platform and stay tuned for our next series of neurology education activities, which will resume after the summer vacation next September. Happy summer vacation. Good night and stay tuned. Assalamu alaikum.
Shukran. Good night, everyone.
Thank you, Dr. Shatila. Thank you, Joel, and everybody. Thank you, Dr. Osama. Bye.
Thank you
Bye.
all. Good night. Bye.